keynote session at 9:25 a.m. 9:25.
拉读巴迪伊、阿邦佐哈里，拉读阿尔马尔、道格拉斯，拉读贾米亚。
Assalamualaikum and a very good morning. We are going to begin our event shortly. I would like to invite those who are seated at the back. Can you move to the front, please? Can you fill in the seats in the front? Thank you. So, some house rules before we begin our event. Number one, please set your phone on silent mode. And for those who would like to access to the conference book can be accessed via the QR code on the screen. So you can just scan the QR code on the screen and it will take you to the conference book. All right, so this is the QR code for the conference book. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Welcome to the second International Conference on Innovative Sciences and Technologies for Research and Education, InnoSTRE. Before we begin the conference, let me share with you the conference program for today. This morning, we will begin our event with the first keynote lecture, followed by the opening ceremony at 10 a.m. The second keynote lecture will continue right after the opening ceremony, and the morning session will end with a lunch break at Hall B at 12:45 noon. The afternoon session is scheduled to begin at 2:15 p.m., where we will have a forum in the Great Hall and the parallel paper presentations in meeting rooms 1, 2, 3, 4, 5, and 8. The afternoon session is expected to end at 6 p.m. and afternoon tea will be served between 5:30 to 6:30 p.m. Moving on to our first session this morning, which is the first keynote lecture. Ladies and gentlemen, the first keynote lecture is presented by Professor Dr. Liang Chao Zhao, Vice President of Anhui Medical University. His title of the title of his lecture is Shaping Our Futures in Higher Education Through High Quality International Collaboration. Unfortunately, due to unforeseen circumstances, he is unable to be with us in person and will be joining us online. Without further ado, I would like to invite the chairperson, Professor Dr. Voon Boo Ho, to be on stage to introduce the speaker. Professor Dr. Voon, the stage is yours.
First of all, thank you very much, the Master of Ceremony. Thank you for coming to this InnoSTRE 2022. Welcome all delegates, honorable guests, right, colleagues, and also the organizing teams. Right, it's my privilege to introduce to all of us this first speaker, Professor Liang Chao Zhao, right, from Anhui Medical University. Right, the title of his paper is Shaping Futures of Higher Education Through High Quality International Collaboration. Let me share with all of us the abstract for his paper. He is saying that the report will discuss the positives of ASEAN-China cooperation in education, as well as the prospects of how to strengthen cooperation in the future, and focus on the analysis of the current situation, problems, and solutions of bi-directional overseas education. So just a bit on his achievement, bibliography. Prof. Liang is the Vice President of Anhui Medical University, Chief Physician and tutor of PhD and MD students in the Department of Urology, the first affiliated hospital of Anhui Medical University, right? Prof. Liang has been devoted to the clinical and basic scientific research of urologic diseases for several decades. Based on his great achievement in genitourinary diseases, he has won a 10 million talent project of the new century, and he is appointed to be the director of Anhui Province key laboratory of genitourinary diseases and the Institute of Urology of Anhui Medical University. The president-elect of the Male and Sexual Medicine Physician branch of the Chinese Medical Doctor Association, the vice president of World Chinese Urologists Association, and Asian Society of Andrology, the chairman of Anhui Medical Doctor Association, the vice president of Intelligent Equipment Technology branch of Chinese Association for Medical Equipment, and the Chinese Medical Doctor Association, the standing director of the Chinese Medical Doctor Association, the urological branch of the Chinese Medical Doctor Association, the chairman of urological branch of Anhui Medical Association, and the standing committee member of Anhui Science and Technology Association. So Prof. Liang has also published more than 600 papers, which include more than 200 publications in SCI journals as the first or corresponding author. Prof. Liang is the editorial board member of more than 19 high-impact academic journals, including the Asian Journal of Andrology. And Prof. Liang held 8 grants from the National Natural Science Foundation of China, NSFC. And he is also the invited referee of NSFC. He is awarded with Chinese famous physician, Golden Stethoscope, Wu Jieping Urology Award, Guo Yinglu Andrology Award, and many others. Prof. Liang also serves as the associate editor or editorial board member of the Chinese Urological Association Guideline and the textbooks for medical graduate and undergraduate students. So up to now, he has mentored over 100 graduate students and postdoctoral fellows. So I can see this keynote speaker has this high profile achievement. Huh? So let us put together our hands and welcome Prof. Liang. Thank you.
尊敬的丹斯里拉杜、巴迪伊、阿邦祖哈里、拉杜阿尔马尔、道格拉斯、拉杜贾米尔、哈马里教授、苏特里斯洛教授、费道斯阿卜杜拉教授、各位专家、各位嘉宾，大家好！今天非常高兴与大家相聚云端，参加此次大会。我代表安徽医科大学对此次会议的召开表示热烈的祝贺，对应邀参加此次盛会的各位领导、专家和嘉宾们，致诚挚的问候和美好的祝愿。感谢麻辣公立大学协办单位、会议组织者为举办此次会议所做的贡献。我们已经一起合作成功举办了2次具有广泛影响的大型国际会议。2020年，我校派代表团赴马来西亚和印尼参会，与当地政府教育官员、高校和中学的师生进行了愉快深入的交流，留下了非常深刻的印象和美好的回忆，也让我们对此今年的盛会充满期待。我今天发言的题目是以高质量国际合作塑造高等教育的未来。我将以亚洲国家，尤其是东盟国家和中国的高等教育合作为例，分析现状，探讨问题，提出一些建议，并重点以双向留学为例加以说明。首先，我向各位嘉宾简要介绍我们安徽医科大学情况。我校成立于1926年，已有近100年的历史。学校位于安徽省省会合肥市。合肥历史文化悠久，有很多高校和重要的科研机构，是中国最重要的创新城市之一。我校有基础医学院、公共卫生学院、药学院、生命科学学院等20个直属教学机构，设有43个本科专业、85个硕士专业、46个博士专业，现有在校学生约25000人，学校及附属医院教职工15000人。我校在科研方面也取得了较好的成绩，在《Nature》、《Science》、新英格兰医学杂志等国际顶级期刊发表了多篇论文，研究成果2度入选中国科学10大进展，临床医学、分子生物学与遗传学、药理学与毒理学等8个学科进入ESI 全球排名前1%。 居全国前列。我校拥有14所附属医院，床位3万多张，医护人员总量3万余人，年门诊量2100万人次，构建了较完备的健康服务体系。我校积极参加国际交流与合作，与16个国家和地区的39所高校、科研机构建立了合作关系，与马拉工业大学等高校合作密切，成果丰硕。亚洲国家山水相连，文化相通，利益相融。东盟是亚洲地区重要的区域性国际组织，是中国的友好邻邦和真诚伙伴。东盟国家和中国加强高等教育的交流合作，自能提升教育质量和科研水平，又能促进人文交流、民心相通。东盟国家和中国高等教育的合作，一是基础好，二是有共同的需求和愿景。东盟国家和中国在高等教育领域已经开展了全方位、多层次、宽领域的合作。东盟5年教育工作计划2021至2025和东盟东南亚教育部长组织2015至2035教育议程，倡议各成员国加强教育国际交流合作。在2019年的东盟峰会上，我国领导人强调要与合作伙伴探索有效的教育合作方式。政府及教育部门之间达成了一系列的协定，为人才培养、科研合作、智库共享等领域起到了重要的引领作用。中国东盟中心、中国东盟教育交流等国际组织和交流活动，为高校间的友好往来搭建了平台。东盟国家和中国开展高质量的高等教育合作大有可为。国际学生的流动是促进高等教育国际交流的重要力量，也是教育国际化发展的重要标志。接下来，我重点以中国东盟双学留学为例，和大家交流目前合作的发展现状、存在的问题，并提出我们的建议。我们先分析国家、省级、学校3个层面的情况和数据。目前，中国是亚洲最大、全球第3大留学目的地，也是世界上最大的留学生输出国。中国学生去欧美国家留学居多，但现在学生选择前往东盟国家高校留学深造的也越来越多。根据联合国科教文组织2019年发布的统计数据，中国学生已成为马来西亚国际学生的首要来源。另一方面，东盟国家留学生也是来华留学的重要生源。目前，中国东盟双向留学人数均超过20万人。近年来，安徽省与东盟国家各方面的合作也在不断扩大，人员往来频繁，在双向留学方面具有很大的潜力。近3年来，我省在册东盟国家留学生分别为2020年619人，2021年750人，2022年以部分新生尚未来校报到，人数目前为543人，分别占我省留学总数的15%、23% 和20%。目前在我省就读的东盟留学生中，来自柬埔寨、印度尼西亚、马来西亚、新加坡、泰国、越南、老挝、缅甸这8个国家。排名前3的生源分别是柬埔寨、印度尼西亚、越南。另一方面，我省目前公派在东盟国家留学的师生为42人，其中在新加坡29人，马来西亚10人，菲律宾2人，泰国1人。这是占我省公派出国留学生总数的4.7%，比例还比较小。我校是安徽省来华留学生最多的高校之一，并专门设有中国东盟丝绸之路奖学金，吸引招收东盟国家的优秀学生。目前，我校有留学生334人，来自30多个国家和地区，其中来自牙买加、印度、摩洛哥的学生居多。东盟国家留学生有15人，其中马来西亚6人，印度尼西亚5人，柬埔寨3人，泰国1人。近5年来，我校招收的东盟国家留学生共11人，虽然人数不多，但每年招生的人数呈上升趋势。但很遗憾的是，我校目前还没有师生在东盟国家高校公派留学。我们正在和马来西亚等国家的高校商谈，通过学分换生等方式增加学生在亚洲及东盟国家的留学派出。通过以上数据可以看出，安徽省与东盟国家双向留学的人数目前还比较少，而且赴东盟的留学生要少于来往的留学生。我们认为主要有以下几个原因导致了这种现象：一是学历学位互认还有障碍，双方可能因为教育体制、课程的体系设置、学习周期不同，导致认证障碍。此外，不同的学校对申请学历学位的要求不一致，也会带来困难。二，学科专业设置国际化程度不够，一是高校国际教育存在偏窄、学科专业设置局限等问题。另外，由于社会结构、文化教育背景、学科专业设置等方面的差异，留学生在本国所学的课程与留学目的国所学的课程可能衔接不流畅，导致学习上有困难，降低了留学的积极性。三、教学语言限制。国际教育通常使用英语作为通用语言，这个给非英语国家的学生带来语言挑战。一是同学的语言水平不能满足学业的需要。另外，很多高校全英文授课的专业和课程不多，选择余地小。四、招生宣传有待加强，高校对外招生宣传渠道较少，学校信息不够丰富，更新不及时，学生对相关情况了解不够。五、受疫情影响，全球超过半数的留学生留学计划都受到了疫情的影响，但是现在来华留学的日境已逐步开放。为了大力促进双向留学的发展，我们建议在以下几个方面继续加强合作：推进学历学位互认，创新合作形式。例如，目前学历学位互认方面 和存在一些障碍，导致一些双学位联合培养的校际合作项目无法开展。希望政府及教育部门之间合力制定具体的发展规划，增强政策制定和制度建设的共识，逐步疏通一些政策性的瓶颈问题。高校可以尽量多地开展学分互换生等项目，以增强留学人数。疫情期间可采用线上交换生等创新模式开展联合人才培养。二，结合自身优势提升培养质量。学校结合自身学科的特色优势，在了解国际市场需求的基础上进行专业课程设置，增加对高层次海外学生的吸引力。三，加大语言培养力度，增加全英文授课的专业和课程，加强英语教学，选派英语水平好的老师为国际学生授课，通过多种文化活动创造语言学习氛围。四，拓展招生渠道，学校可在国内外知名的招生网站或委托国内外教育咨询机构做招生宣传，丰富宣传材料，通过增设各类奖学金名额、开展文化体验活动等方式吸引生源。五，加强数字化教育建设，完善和共享线上教育资源平台，完善全过程的留学管理服务体系，能够实现申请流程全部线上办理，同时为留学生在线上提供政策指导、签证办理等配套的助学服务。各位嘉宾，中国语老话说，单则易折，众则难摧。让我们携手同行，戮力同心，共同创造高等教育、高质量国际合作的新篇章。最后，我诚挚地邀请各位朋友在不久的将来访问安徽医科大学，祝大会取得圆满成功，谢谢大家。
This is a new horizon. One we'd never imagined. In a land as old as time lies the ancient wisdom of mankind. We are all in search of something greater to find meaning in the mysteries long forgotten. What if we went back to where it all began and reconnect with our origin? Now feel the rhythm of Sarawak.
Ladies and gentlemen, we were supposed to play a few videos on Sarawak for our international conference participants. However, our VIP is already here. So unfortunately, we have to cut the video short, but we will play you the videos maybe after the opening ceremony or after the second keynote speech. Ladies and gentlemen, please be upstanding, announcing the arrival of the Honorable Dr. Roland Saga Wee In, Minister for Education, Innovation and Talent Development, Sarawak. And gentlemen, please remain upstanding for the national anthem, Negaraku, followed by the state anthem, Sarawak Ibu Pertiwiku. seated. Next is the welcoming dance. The welcoming performance of Sarawak Creative, Ethnic and Putri Sentubong dance is choreographed and performed by the dancers from the deaf community under the Sarawak Deaf Art and Culture Association. Despite not being able to hear, these deaf dancers are so passionate about dancing and are able to feel the beat of the music. Let's give them a round of applause by waving our hands like this as a symbol of clapping in the sign language. Ladies and gentlemen, put your hands together for the Sarawak Deaf Art and Culture Association.
Inu dengar, inu dengar kembung tuyang, inu dengar laikam dalam dosa.
Kalau nak cenaa kedingian nalan Pabati bola ketu yang cadang natoy payun paman nalan Putri Santubo sejinjang kisah lama zaman mensia maya Putri Santubo putri sejinjang menjaga gunung negeri Sarawak masih ada dapat dilawan anak dewa turut kayangan Santubo puteri bertenun kain sejinjang puteri menumbuk padi siang satu harinya dua kelai berano-ano si henti-henti seorang mana pilih bagus lagi seorang si kalah walau sampai ke mati Santubo puteri bertenun kain malam sejinjang puteri menumbuk padi siang udah lejutnya dua kelai lalu bertubuhnya dua puteri sejinjang mengayun alok ke pipi lebih Santubong sampai gitu hari tapi Santubong membalas jua lalu ditikam batang belidak sampai terkena sejinjang kepala lalu berterabur jadi pulau gerak kisah Santubong kisah sejinjang asal berkawan jadi musuhan kini kau tinggal jadi kenangan bagai ingatan sepanjang zaman Putri Santubo putri sejinjang putri Santubo putri sejinjang putri Santubo putri sejinjang putri Santubo putri sejinjang
Ladies and gentlemen, that was the Sarawak Deaf Art and Culture Association. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. The Honorable Dr. Roland Sagah Wee In, Minister for Education, Innovation and Talent Development, Sarawak, representing the Right Honorable Dato' Patinggi Tan Sri Dr. Abang Haji Abdurrahman Zohari Bintun Dato' Abang Haji Openg, Premier of Sarawak and patron of the Second International Conference on Innovative Sciences and Technologies for Research and Education 2022. Associate Professor, Chemist Dr. Muhammad Isa Muhammadin, Deputy Rector, Student Affairs, UiTM Sarawak, representing Professor Datuk Dr. Jamil bin Haji Hamali, Rector, UiTM Sarawak. Professor Dr. Kong Heng Yen, Co-Chair of InnoSTRE 2022. Associate Professor, Dr. H. Junaidi, Dean, Faculty of Business and Economy, Universitas Jambi, Indonesia. Ms. Emilia Rosiman, Chief Executive Officer, Business Event, Sarawak. Heads of departments, keynote and plenary speakers, members of the media, conference participants, ladies and gentlemen. Welcome to the Second International Conference on Innovative Sciences and Technologies for Research and Education, InnoSTRE 2022. Without further ado, I would like to invite Ustaz Muhammad Ilyas bin Muhammad Saleh to be on stage for Doa recitation.
Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala ashrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Allahumma ja'al jam'ana hadha jam'an marhuma wa tafarruqana min ba'dihi tafarruqan ma'suma wa la taj'al fina wa la ma'ana shaqiyyan wa la matrudan wa la mahruma. O Allah, we beg thee of all good things which pertains to this day and days hereafter, and seek thy protection from all evil which pertains to this day and days hereafter. O Allah, you are peace, and all peace is from you, and all peace returns to you, O Master of power and glory. In conjunction of the Second International Conference on Innovative Sciences and Technologies for Research Education, InnoSTRE, that will be launched by our guest of honor, the Honorable Dato' Roland Sagah Wee In, Minister for Education, Innovation and Talent Development, Sarawak, representing the Right Honorable Dato' Patinggi Tan Sri Dr. Abang Haji Abdurrahman Zohari Bintun Dato' Abang Haji Openg, Premier of Sarawak. Guide us among those whom you guide, grant us health and pardon among those whom you grant health and pardon. O Allah, we ask you for beneficial knowledge, good deeds, a strong memory, and a perfect understanding. Ya Rahman, Ya Rahim, honor us by the light of understanding and take us out from the darkness of doubt. Ya Fattah, Ya Razzaq, open upon us the doors of your knowledge and open upon us the treasure of your recognition, O the best of the merciful ones. Rabbana atina fid dunya hasanah wa fil akhirati hasanatan wa qina adhaban nar. وصلى الله على خير خلقه سيدنا محمد وعلى آله وصحبه وبارك وسلم سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين.
Amin, amin, ya Rabbal Alameen. Thank you, Ustaz. The theme of this year's conference is probing the societal challenges through a unified interdisciplinary platform. We are proud to share that this conference has attracted 250 participants from 8 different countries, namely Australia, Thailand, China, Cambodia, Indonesia, Russia, United Kingdom, and our home country, Malaysia. Ladies and gentlemen, next is the welcoming speech. Our Vice Chancellor is unable to join us in person today. However, she has pre-recorded her speech. Please turn to the screen in front of you for the welcoming speech by Dato Technologies Professor Dr. Roziah Muhammad Janur, Vice Chancellor of University Technology Mara.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Hormat Datuk Patinggi Tan Sri Dr. Abang Haji Abdul Rahman Zohari bin Tun Abang Haji Openg, Premier Sarawak. Yang berbahagia Profesor Datuk Dr. Jamil Haji Hamali, Rektor UiTM Cawangan Sarawak. Yang berbahagia Profesor Dr. Liang Chao Zhao, Naib Presiden Anhui Medical University China. Yang berbahagia Profesor Dr. H. Sutrisno, Rektor Universitas Jambi, Indonesia. Yang berbahagia Profesor Dr. Firdaus Abdullah, Dekan Fakulti Perniagaan dan Pengurusan, merangkap pengerusi InnoSTRE 2022. Yang berusaha Profesor Dr. Kong Heng Yin, pengerusi bersama InnoSTRE 2022. Keluarga besar Universiti Teknologi Mara, UiTM Cawangan Sarawak yang berada bersama kita pada hari ini. Para tetamu jemputan dan peserta-serta hadirin yang saya hormati sekalian. Alhamdulillah, syukur kehadrat Allah Subhanahu Wa Taala kerana dengan limpah dan kurnianya dapat kita berhimpun bersama-sama di dalam majlis pada hari ini. Lebih dahulu, selamat datang kepada semua yang berada di sini. Syabas dan tahniah saya ucapkan kepada pihak UiTM Cawangan Sarawak kerana telah menganjurkan Second International Conference on Innovative Sciences and Technologies for Research and Education, or in short, InnoSTRE 2022. Setinggi-tinggi penghargaan juga buat Kerajaan Negeri Sarawak atas sokongan dan kepercayaan yang diberikan bagi memastikan persidangan ini dapat berlangsung dengan penuh gemilang. Hadirin yang dihormati sekalian, bagi meneruskan majlis, izinkan saya untuk berucap dalam bahasa Inggeris. Ladies and gentlemen, probing the societal challenges through a unified interdisciplinary platform, this year's theme manifested our efforts in pursuing the Sustainable Development Goals, or in short SDGs, by creating a new sense of synergies and demonstrating the leveraged power of creativity to cope with the challenges through a unified interdisciplinary platform. Understandably, we are in the midst of a crisis like no other. But the pandemic has sent a chilling nerve to the spine of the global economy. People across nations are worried about what the future holds for them. While the government stretches its spending capacity, policy works extremely fast to avoid economic fallout while facing underlying threats to its financial system stability. Hence, this international conference shall provide a premier platform for researchers, practitioners, and educators to share and discuss the most recent innovations, trends, concerns, and solutions to practical challenges in various areas. Ladies and gentlemen, since the first establishment of Samarahan campus in 1973, we have about 7,920 students enrollment only in Sarawak. With over 800 staff members, we can work together to achieve global competency through research collaborations, entrepreneurial initiatives, and innovative education. As a Vice Chancellor, I have taken efforts in steering a new culture of excellence to expand the university's global visibility among academics, administrations, and also students. We have been accelerating our collaborative research with our local and international partners to help the development of this country. As one of the largest comprehensive universities in Malaysia, UiTM holds the responsibility and a formidable task to help find solutions and alternatives for many to adopt while facing the inevitable challenges in life. Ladies and gentlemen, it is pleasing to have this conference covering a wide range of areas, namely economics, finance, social and community, medical, health, tourism, travel, education, trade and business, agriculture, food security, cyber security, and many more. We should be able to oversee all areas and discover the potential for more sustainable alternatives. UiTM Sarawak branch has witnessed the state's exponential growth during its first decade, cementing the institution's reputation for contributing to society through education and research at different levels of excellence. UiTM support to the Sarawak state government has led the initial development of UiTM Mukah campus to be in tandem with the 9 Malaysia plan. We have been supporting the state's initiatives and playing a key role in driving the state's economic growth by ensuring the programs offered by the UiTM Sarawak branch comply with the needs of the state government's long-term growth, especially economic corridor. Ladies and gentlemen, let us congratulate the esteemed committees of InnoSTRE 2022 from University Technology Mara Sarawak branch under the leadership of their rector, Professor Datuk Dr. Jamil Haji Hamali. And this conference is co-organized with Anhui Medical University China and Universitas Jambi, in short UNJA, Indonesia. This conference is supported by the Sarawak government, Business Events Sarawak, Malaysia Convention and Exhibition Bureau, in short MyCEB, Asian China Education and Culture Association, ACEC Association. In addition, many academic partners are also supporting this conference, including Universitas Muhammadiyah, Surakarta, UMS Indonesia, Islamic University of Riau, UIR, Indonesia, Raja Manggala University of Technology, Tanyapuri, RMUTT, Thailand, and Teacher Education Institute of Malaysia, Batu Lintang, IPG, KBL. More than 140 papers will be presented by international and local participants over 6 hybrid parallel sessions. A forum entitled Pharmaceutical and Nutraceutical Innovation will be organized in conjunction with this second InnoSTRE 2022. And this forum will gather 7 panelists from Anhui Medical University, China, Immanuel Kant Baltic Federal University, Russia, University of Bath, United Kingdom, Macau University of Science and Technology, China, University of Hong Kong, Vitai Sdn Bhd, Malaysia, and Eman Research Ltd, Australia. The panelists will present their knowledgeable insights about critical considerations of pharmaceutical and nutraceutical innovations. Thank you from the bottom of my heart and well done. To all distinguished speakers and participants, let me once again extend my warmest welcome to all of you, and I hope you will find the experience of this conference to be rewarding. Before I end, allow me to express my confidence in this conference. I am sure it is beneficial to everyone with a very productive conference, exciting and encouraging discussions, as well as knowledge sharing to anticipate a groundbreaking knowledge and alternative for future humanities. On that note, I wish you all good health, and I hope you have an immensely joyful time at InnoSTRE 2022. With that, thank you. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, that was Dato Technologies Professor Dr. Roziah Muhammad Janur, Vice Chancellor of University Technology Mara. Thank you, Dato, for the speech. Next, representing the Right Honorable Dato Patinggi Tan Sri Dr. Abang Haji Abdul Rahman Zohari Bintun Abang Haji Openg, the Premier of Sarawak, we would like to invite the Honorable Dato Roland Sagah Wee In, Minister for Education, Innovation and Talent Development Sarawak, to deliver the speech on behalf of our Premier and officiate our event.
Terima kasih kepada saudari pengacara majlis. Yang bahagia Associate Professor Chemist Dr. Muhammad Isa Muhammadin, Deputy Director Student Affairs, UiTM Sarawak, representing Professor Dr. Jamil Haji Hamali, Director of UiTM Sarawak. Yang Besar Professor Dr. Kong Heng Yen, Co-Chair InnoSTRE 2022, Heads of Department and Units, keynote and plenary speakers, friends from the media, conference participants, ladies and gentlemen. First of all, I would like to convey our Premier's apology for not being able to be with us to give his keynote address this morning due to some urgent and heavy commitments. In any event, let me welcome you with a very good morning and salam Sarawakku sayang. We wish to thank God Almighty for giving us this opportunity to be here today for the launching of the second International Conference on Innovative Sciences and Technologies for Research and Education, or in short, InnoSTRE 2022. I would be very honored, especially the foreign participant, to welcome you and to say Selamat Datang. And most of all, because you come to Sarawak, welcome to Sarawak in Malaysia, the land of the Hornbills. It is a remarkable collaboration or collaborative effort by UiTM Sarawak to invite foreign delegates, participants, and distinguished professors to be part of this international conference. Additionally, I'm very grateful to Professor Dr. Jamil Haji Hamali, Director of University Technology Mara or UiTM Sarawak, and his UiTM team for taking the initiative to launch or to organize the international conference, a collaborative effort with Anhui Medical University of China and Universitas Jambi, UNJA of Indonesia, and supported by ACEC Association, with the aim and objective to provide a platform for academicians, non-academicians, practitioners of government and private agencies to foster and transform their thoughts, ideas, and research into output with potential commercial value to help in the economic growth for the natural sciences, engineering and technology, education, humanities, and social science-related industries. Ladies and gentlemen, the theme of the InnoSTRE 2022 conference that is probing the societal challenges through a unified interdisciplinary platform is very close and relevant to what we in the ministry, that's my ministry, the Ministry of Education, Innovation and Talent Development are doing and aspiring to do and to achieve. With a goal to have the competitive talent to drive Sarawak's aspiration, the government is striving continuously towards excellence. I believe that the presentations of this conference will help us to shape and construct effective policies for the betterment of Sarawak and, of course, the nation Malaysia. I am looking forward to discovering various themes and topics covered in this international conference that will contribute to the rapid advancement of advancing talent competitiveness in Sarawak. I also envision the societal challenges highlighted in this conference would bring both education, innovation benefits and improve the well-being for the rakyat, the people. It would be a natural progression for the ministry as breakthroughs in modern technology and practice have already been identified as a key growth engine under the objectives of the 11th Malaysia Plan. This places it under the radar of the government economic transformation program towards a developed nation status. Together, these developments will reshape the sustainability landscape and help shape the future of the standard of living, particularly for Sarawak. Therefore, this international conference will be a platform for scientific researchers and practitioners with similar interests to be aware of recent updates in their fields. And this will help to advance knowledge and its application. Ladies and gentlemen, I wish to see the extended version of this knowledge to be explored in depth by all the prominent researchers who participated in this conference. I look forward to some unique, innovative ideas, remarkable findings in relevant fields, and sustainable solutions to existing problems in improving Sarawak's education, innovation, and talent drive. The societal challenges are rapidly evolving. Therefore, the second InnoSTRE 2022 is just in time to introduce and explore societal challenges through a unified interdisciplinary platform that will benefit education and innovation in the state. Indeed, my ministry is looking forward to hearing new ideas, research findings, and suggestions from everyone presenting their ideas and papers in this conference. We welcome your feedback and suggestions or inquiries made in relation to my ministry and would like to serve you better. Before I conclude, I wish to congratulate all the agencies and institutions for launching this and for organizing this international conference. This collaborative effort is commendable and should be continued in the future. Well done. Shabash. Give yourself a big applause. To the organizing team, thank you for committing your time and energy to this international conference. I hope the second international conference on innovative sciences and technologies for research and education, or InnoSTRE 2022, can become a strategic platform where catalysis scientists and ideas from both worlds first meet to find solutions to those problems. I am confident and that the conference objectives will be met and that all will benefit immensely from this conference. I wish you all the best and an excellent conference. I hereby, on behalf of our Premier, launch or declare open the second international conference on innovative sciences and technologies for research and education, InnoSTRE 2022, officially open. Thank you.
Thank you, Dato. Please remain on stage. We would like to invite our VIPs, Associate Professor Chemist Dr. Muhammad Isa Muhammadin and Professor Dr. Kong Heng Yen to be on stage for the opening gimmick and montage. For the gimmick, the Honorable Dr. Roland will place the plaque on the launching pillar on stage as a symbol that marks the start of the second International Conference on Innovative Sciences and Technologies for Research and Education.
Innovation ecosystem include university-based research laboratories focusing on big data and data analytics, 5G, immersive technologies.
and gentlemen, that was the montage for InnoSTRE 2022. To our VIPs, please remain on stage. Next is souvenir presentation. We would like to invite Associate Professor Chemist Dr. Muhammad Isa Muhammadin to present a memento to the Honorable Dr. Roland Saga We In as a token of appreciation. Thank you. You may return to your seats. Ladies and gentlemen, next we will have a group photo session. For the photo session, we will adhere to the new norm and follow the standard social distancing practices. So please remain in your seats and our photographers will be on stage to take the group photo. Ladies and gentlemen, this marks the end of our opening ceremony. We were informed that the Honorable Dr. Roland has an important engagement at noon and will not be able to stay for the next session. We thank you, Dato, for being here with us this morning. For our conference participants, please remain in the hall for our second keynote lecture. Ladies and gentlemen, to give time to our keynote speaker and chairperson to prepare for the next session, we will play you a video about Sarawak.
dari miat-miat keliak. Aku ada sebab lahir, ada dia baru meh dia. Jadi banyak aku cuba aku bisik sekolah, bawa sekolah SK dengan ibu. Tapi dia suruh aku minat dapat nak pom 2 aja. Karena apa nama tanya kembar aku jadi kami dua sama-sama. Nada boleh nampung lagi sekolah ketinggi ke banyak laban kurang belanja. Jadi sekolah sekondari itu jauh hari kami tahu lah. Ya baru bantu dia. Dari perahu ke Tambayang. Yang nak band lagi sekolah ke Tambayang ke. Makanya baru ke pulai lah. Jadi tiap 10-20 nak cukupnya. Jadi dalam tahun 2011 apa aku dan ada parai mainnya. Ini apa aku madah sebab leban te aku parai lah nak dek nanti aku pemain-main kita madai dek mah ke layak pihak aku ya. Jadi mainnya umur aku 30 lah. Umur biak nah. Okey biak. Jadi tuan rumah. Puasan batang air tu. Aku lah tuan rumah ke paling biak di tu pemaduk biak. Dari segi akademik lah saya pintar. Aku medak baru rumah panjai kami tahu segi kurang hari clear. Nah ada bisa orang dah graduate gitu. Nya aku medak balan biak di tu. Mayu agak baduk nyumbakau penyakit aku yang tadi baduk nak pom 2 pom 4 bisa. Jadi harapan aku berketok lah laban tok tadi aku baru-baru tu aku dah bisa nerima projek ke cukup berguna bagi kami serumah. Hanya mini perpustakaan tadi. Sudah ada buat dewan atas dia. Nyala aku ngarap ngau bisik library nyala lalu bisik gak sidak boleh belajar, boleh nambah ke pengetahuan sidak ya, penemu sidak ya.
And the reason why we choose Nanga Ukum is that when we talk to the Longhouse people, especially the Tuai Rumah, they share their opinion about the development of education for the youth in this area. And it's really touched our hearts because for some of us, this really reminds us of our own humble beginnings.
You really experience, you see it from your own eyes that what happened in 2016, the promises, and what is the meaning of gift of love that B Sarawak has promised to the community. We talk about community development and they're setting up a better environment for the Longhouse community. You see the children, how happy the children are. They have a library, they can hang out, and they can look at the books, they can gain knowledge and feel fun and create the interest of reading.
In terms of how a congress, how a conference could actually bring about impact to the local communities. So that's why the idea is very noble and we are happy that we are successful today to have handed over this one of the first initiative for a community library that we have.
By having a mini library over here, it will make a difference, it will change, and it will give them an education that will not just break the cycle of poverty, but at the same time, giving them an alternative in life to be able to choose what they want to do and to achieve their dreams. So we are so lucky and so blessed to have Tuai Rumah. He is our champion. Because without him to lead the rest of the community, this project would not be sustainable.
Kira nakaknya dulu lah kita aku. Mari saya terima kasih nagai balaka udah menemu buah aku tadi. Terima kasih.
Okay, ladies and gentlemen, we are ready for our keynote address. Let me just check. Professor Dr. Wong is here and Dr. Amin Malik. All right, so we'll just give him another 5 more minutes.
It's okay. Don't worry. It's okay. Don't worry. I think she's very formal. I invite myself. Yeah, having watched the very touching, how should I say, the video recordings, I guess all of us are very lucky. We are, well dressed, sit in the air-conditioned hall, and we are going to listen to Dr. Amin, and we are thinking about the lunch that is going to be served later. So I guess we are more than, how should I say, lucky, right? So the next keynote speaker is Dr. Amin Malik Shah Abdul Majid. Dr. Amin has about 18 years of experience in academic as well as industry. Now, he has supervised nearly 100 postgraduate students with more than 300 research publications. So he works a lot with the Malaysian and Australian universities. And most of his work lies in the field of botanical drugs targeting angiogenesis, particularly for cancer applications. And he has a rich experience in clinical studies pertaining to breast cancer, colon cancers, diabetic retinopathies, right? And just now, on the way to the hall, so he told us that, he's aiming to sort of release the first botanical drugs as a cancer therapeutics. So I really hope that this can be one of the milestones for Malaysia. Yeah? So without further ado, let's welcome Dr. Amin to share his insight on angiogenesis targeted botanical drug development, a successful platform in botanical medicine drug discovery. So Dr. Amin, yeah. Okay, no worry, you can cover your slide. Yeah.
Okay, Bismillahirrahmanirrahim and Assalamualaikum warahmatullahi wabarakatuh and good morning. Firstly, I would like to thank the organizing committee for inviting me to participate in this conference. I'm really much honored. I'm very, very happy to be here in Sarawak. I really like Sarawak. It's a beautiful place. I'm originally from Penang, but currently I reside in Canberra. It's like a Australian version of Putrajaya, but with less trees. Okay, I'm representing Iman Research. Iman Research is Australian public not-for-profit organization. It was established and funded by some of these companies, Natureceuticals and Iman Biodiscoveries, some of the companies which I helped to establish. The whole purpose of Iman Research is to help to promote botanical drug research and development to developing and underdeveloped countries. Our aim is to share our experience where we have succeeded and where we have failed in order to teach all the other scientific community and industry players in terms of how to make herb into prescription drug. So if you look at the, let's start with the main objective, why we're doing this. In terms of our product development is trying to target these issues, which is global death. In terms of death, we have about 54 million people dying annually of various sorts of conditions, diseases, and also including accidents. But the fact is, we have to understand that our recent pandemic, 6.5 million people died of the COVID-19. And guess what? Annually, we have about 18 million people die of cardiovascular diseases. 10 million people die annually of cancer. So if you look at the COVID-19, it's actually is quite small. But if you understand further, look at various countries, underdeveloped countries, their disease, their death rate, the type of diseases they suffer from is different than developed countries. So the priorities for drug development for developed countries is different compared to developing countries. So understanding this and understanding that this fact, so our priorities as a developing or underdeveloped countries will be different compared to developed countries. If developed countries are the ones who are leading in drug development, the drugs will be developed mainly to cater their needs and not to our needs. So if you look at the cost of drug development, it has been estimated the cost of drug development is up to about 2.17 billion US dollars. But again, this cost is based on pharmaceutical giants because their cost of developing drug is a bit different compared to our approach. Maybe us as academicians, we can sit on one molecule and spend 18 years working in our lab, and the cost is basically our salaries and some grant. Compared to drug companies, they'll be screening hundreds and thousands of compounds every week. So their cost is much higher because they need to get return of investment much faster. But the key thing is, the cost is very high, conventional medicine. And it can take up to about 15 years to develop a drug. And these are issues that we need to understand. But if you look at why the cost of drug development is so high, one is of the major issue is due to failure in clinical studies. We only hear successful clinical studies, but 95% of clinical trial will fail. So somebody have to pay for that. So I briefly like to educate all of us, maybe not of us, all of us in the pharmaceutical development field. For the drug development, we have two major areas. One is the preclinical and the other one is clinical. Preclinical, you're testing in cells, tissues, animals, and clinical where you actually do trial, human trial. In this preclinical, it may take a very short while, or it may take a very long while depending on your approach. Like for example, the COVID-19 vaccine, when it was first produced, it bypassed major component of this process. For example, when the trial was done in human trial, there was very limited animal toxicology data. But that is the major requirement for drug development. Safety is the most important thing. Once it is safe, the regulatory authority is confident that the product is safe, only then they will allow you to go to the next level to do human trial. And the human trial, that is when you need to prove that your drug is effective compared to placebo. Because placebo is a major problem, all right? Almost 40% of clinical trial, when you give a blank, which means placebo, the patients seem to respond. So that's why sometimes I argue when you go to, we call it the bomoh, the witch doctor. When you go to the witch doctor, when they give you some potions, whatever, the fact that you're feeling good about it, you feel that you're going to be cured, it somehow rather have curative effect. Maybe it reduces your stress, and only then your immune system will start kicking in, and then your disease burden will probably reduce. So there is some potential therapeutic properties there. But when we do conventional trial, we need to show a placebo compared to the tested drug. So this clinical trial can involve thousands of patients depending on the safety. Like for example, when the vaccine, because the vaccine there is issue of toxicity. And so they have to do large number of patients to show that the risk and the benefit of taking the vaccine. So all these things contribute to the cost of the drug development and time frame. But of course, regulatory authorities, they have the final say. Donald Trump, when he became the president of America, he tried to shortcut this thing. But even the president of America couldn't shortcut this. Who are we to do this? But there were talking about instead of doing such large number of trials, maybe we can do smaller number of patients. This can probably reduce the cost, but also may increase the risk of adverse effect if the drug is not proven effective. So again, keyword safety, all right? So you're starting with a new synthetic drug, has ever been created before. No animal species or human species been exposed to it. So therefore, there are a lot of risks and dangers that we worry. Many years ago, when I was doing my PhD, that was like year 2000, it's a long time ago. I used to design synthetic chemotherapy drug to reduce side effect and trying to make the compound more specific to kill cancer cells. Because the problem with cancer cells is they have ways to fix, to develop drug resistance. So when you have chemotherapy drug targeting the DNA to break it up, the cells has its ability to repair and regenerate, or even to, I would say, literally spit out the drug. And that's how it developed drug resistance. So the reality is diseases are complex. It is not as simple as what we think. The more we learn, the more we know, there are a lot of things that we do not know. So there are more and more mechanisms coming in. So when you find that, if you look at this pathway that was 30 years of research on cancer pathway, you find that to develop a drug that can effectively treat cancer, you need many, many drug targets to target different pathways, which is not economically viable. Yeah, because each drug costs money. You can't be giving hundreds of drugs to a patient and it's not viable. Okay. Now, this is the nice word, polymolecular medicine. Medicine with many molecules. Herbs, natural products contains lots and lots of molecules inside there. Each one of them doing its specific things. In real life, if your car breaks down, your engine needs to be overhauled. You can't fix it with a screwdriver. You need lots of tools. Complex diseases like cancer, heart diseases, you need lots of different ways or molecules to treat the patients. But herbal products contain many molecules which may cater to our needs. It may boost the immune system, it has anti-inflammatory, antioxidant, and so many things that has beneficial therapeutic outcome. And the good thing about herbal-based pharmaceutical, if it has long established use, the safety is known. If let's say today I want to make durian to treat cancer, I say, okay, this is my product based on durian to treat cancer. You won't ask me about safety because, you know, I've been eating durian. My grandmother been eating durian. It is safe. So I'm quite happy to take it, right? So if you go to regulatory authorities, oh, I'm using durian extract to treat cancer. And if they look at it and they say, oh, okay, this durian is a safe product, you know, have a good safety profile, I will give you a chance to do clinical studies without extensive toxicity data. Yeah. So these are things, you know, safety issues becomes better. Or if you know a particular herb that has a certain effect, Tongkat Ali, people take Tongkat Ali for male libido. So many people have been taking Tongkat Ali and they know that it somehow or other is effective. And we know somehow or other is safe and effective. This reduces the risk of failure in clinical studies. So it brings down the cost. Synthetic medicine, number one, you don't know whether it is safe. I mean, you know in the animals it is effective, but you don't know whether it's effective in human. So this is what we call reverse pharmacology. You know something that is working and you reverse it to make it compliant to regulatory requirement as a drug. Okay, so this is different. You cut down your cost, right? Reduce your risk. Now, unlike synthetic medicine, they are consistent in quality because you know what you're producing. It looks exactly the same. You use analytical method, you know what is the molecular of that particular molecule of that drug. But natural herbal extract got hundreds of compounds, some known, some unknown, all right? Talking about durian tree, maybe your durian tree, your fruit from the durian tree is not going to be exactly sweet every season. There may be some seasonal variation, right? So just imagine that guy, you're giving durian-based extract for cancer treatment. You tell the patients, hey, you know, this season was raining, the durian quality is not very good, so the active compound has decreased. Instead of taking 1 capsule, you have to take 2 capsules a day. So, oh, really? Okay, it's fine. Just imagine you have to inform that to thousands of patients throughout the world. So these are challenges, how to make sure the consistency in quality to make the product consistently effective. Yeah. So these are issues, challenges when you develop botanical drug. And sometimes, you know, the product just work. You ask, what is the mechanism of action? What is the active compound? Say, I don't really know what is the mechanism of action. I don't really know what is the active compound. But hey, it works. Give Tongkat Ali and, you know, it does the job. Oh, okay. Do you really need to know what, how it works for it to be approved as a drug? The thing is, it's not really necessary. As long as you can show safety and you show effectiveness in the clinical trial, regulatory authorities will be able to approve your drug depending if they are comfortable with your product. So long ago, until even today, people are saying herb cannot become a drug. Right? You go to any medical doctors, you go to many even scientific meetings. If you tell them, hey, do you know herb can become a drug like any of the drug out there approved by the regulatory authorities? Say, no, impossible. Herb cannot become a drug. Tell you what, you're wrong. The US FDA, the European Medical Agency, WHO have approved a guideline in 2005 for herb to become prescription drug like any other drug in the market. Have you heard about this? Most people didn't know. And guess what? Finally, Malaysia, our country, 2019, approved a guideline called Natural Product with Therapeutic Claims that allow herb to become prescription drug. Do you know that? You can make durian become a drug if you follow the criteria. So the criteria is still the same, only that the safety issues will be probably less requirement. But for our case, we still have to do the necessary toxicology data, all kind of stuff. But you still have to do the robust clinical studies to show efficacy and safety. But hey, herb can become a drug. And this has become, in fact, our project has become a national interest project in year 2010 under the NKEA, whereby the government, the Malaysian government funded our project for herb to become a drug so that it create income for the country and generate employment for Malaysia. So now these are why we are here. But in the world, unfortunately, with all the guidelines, there are only less than 5 botanical drugs being approved by the regulatory authorities because the scientific community, the industries, they don't understand how to make herb into a drug, how to make herb speak the pharmaceutical language. And this is what we are, why we are here, why I'm standing here to share some of our experiences. So us as scientists, at the scientific, among the scientific community, to make the world go round, we know it's all about money because you need funders to fund your project. Then funders also need to feel safe that their project that they fund is secured. But you need to speak to them in terms of language of money. Okay, how much money if you fund, this is how much I need and this is how much I can produce as a drug. So if you produce a durian, again, as I say durian, if you produce durian, I like durian very much. I think durian is the best fruit in the world. If you say durian, you think all durian is the same. I say, no, Musang King, Blackthorn, I'm willing to pay more. Why? People know it tastes better. Right? But I think Penang durian tastes better anyway. That's my opinion. But the fact that if your product, your particular fruit or plant that has gone through that processes, you know, validation, safety, consistency, whatever, it is only for your product. If somebody else want to do the same thing, they can't. The regulatory authority say, hey, is your plant, is your plant has the same genetic profile as the other person's plant? Did you cultivate in the same way? Did you use this fertilizer? Is this how your extraction is? Is this how your formulation is? They are different. So that's why the cost differs. So the highest level is when you do, let's say, your standardization. Okay, this product is standardized to this active compound. Well, the price is okay, 5,000 ringgit per kilo. But if that product is coupled with safety and clinical studies, the price is different. Okay, so this is called botanical drug. So when you have clinical data backing it, here it becomes a drug. I'm talking about prescription drug. I'm not talking about testimonial. All right. If today, if I make my product, I go around and advertise, okay, this is for treatment of COVID-19. The NPRA will come and put me behind bars. But if I have done the clinical studies, the safety and stuff like that, and get marketing approval from the regulatory authority saying that this product is effective for COVID-19, it is fine, right? So that means it's a prescription drug. Who's going to give the drug? No, you cannot just buy online. It's going to be doctor's medicine. It will be covered by insurance or by the government hospitals and stuff. So that is where the difference is. So there are different way of marketing, but the revenue is much better, but investment is more, is higher. So we speak in terms of language. This is a language we spoke to the government. We said, hey, if you fund this project, our project costs millions and millions of ringgit. So if you fund this project, this is how much it will generate income. So, oh, that is a lot of money. I said, the bridge in Putrajaya? Yeah, I saw the one not finished. This one, 2 kilometers of that bridge will cover the cost. I said, is that expensive? Oh, so that's not expensive then. How you present the project. And because this is not once off, it's going to generate income. And not only generate income, you may potentially produce a product that can save life, maybe better than what's out there. So, to summarize, in terms of botanical drugs, safety is there. Efficacy is, the effectiveness is may be potentially people really using in the community. Effectiveness there is potentially there. Less intellectual property constraint. This has a double-edged sword. Okay, if you do Tongkat Ali and then somebody else also do Tongkat Ali, the patent protection, there are many ways of filing patent. There are patent and there's regulatory authorities. You file patent, you don't want people to copy your work, but regulatory authorities, they also look at, they don't look at it at such way. They look at, they are different. Your product, your method, like I mentioned just now, is different. Your seed, your genome is different. So there actually can be a more robust intellectual property for the product that you develop, because people can't copy. If they want to copy, they have to do all the tests all over again and spend that millions of dollars. And also lots of scientific data. You can see these herbs, whatever, there's some studies in that, that means you already have you have a good starting point. For synthetic medicine, newly developed, you have to start from fresh. Yeah. And generally the method of processing is cheaper, right? And you can, if the product is based on already safe herbal product, there are contract manufacturers that can produce for you. You can produce as a supplement to have in the market, right? But don't go around claiming for cancer, but you can for health supplement, for health needs. And then slowly you developed it as a drug. Yeah. So this is the same thing which I highlighted just now. Yeah. But one of the issue earlier on, with botanical drug, the guideline, regulatory guideline also not very clear. Although there's a guideline, it's not very clear. We've gone through it. When we wanted to develop our factory, build a factory to make herb into a drug, the regulatory authority said, there's no such thing as a factory for herbal drug. Herb is not a drug, herb is food. So we said, no, But for herb to become a drug, it needs to be developed in a pharmaceutical environment. Sorry, that's not in our guideline. You build, but we will not certify you for that kind of GMP. So, and then at that time also, when we wanted to do clinical trial in Malaysia, oh, you can't, because herb is not a drug. So you cannot do such a clinical studies. So we had to go overseas where there are other countries where those guidelines are there. So I won't talk about intellectual property. I've already talked about the intellectual property just now. So high quality scientific publication. When I was doing my DNA targeted drug design, the impact factor publication was around 6-7 impact factor. But when you do herbal research, suddenly to get one impact factor, so struggling, right? It was a challenge. So you have to downgrade. Really, you have to reinvent the kind of things. But then we learn how to go about it, how to use the words in scientific literature to publish, to get that high impact factor publication. Okay. And also some of the issues that we learned was the herb, the extraction, the research that we do in the lab is not commercially viable. Regulatory will not approve. I learned that from a terrible mistake. It was methanol extract. Wow, fantastic methanol extract. But then you go to the factory, say, can you produce methanol extract for me? Hey, crazy, that's poisonous. Our staff will be exposed to poison. Regulatory authorities say, no way, I'm not going to approve your methanol extract. So all the years you spent was wasted. You have to do it all over again. Or sometimes you make an extract so good, but the cost is so high, and you do for hypertension. Say, why should I pay a few $100s for per tablet when I can buy the synthetic ones cheaper? So these things we need to be aware as a researchers and the one who develop drugs and at the early phase, so that we don't make the mistake. Oh, there's one project was fantastic. The product was so good. It came from a tree extract. But the tree takes 7 years to grow. 7 years, how am I going to supply to the world requirement, the world needs? So again, these are things that you need to understand. So while we are sleeping, and we are the country which is highly diverse in terms of our biodiversity, the developed countries, they are already doing hundreds of research, filing IND, investigator new drug with the US FDA for botanical drugs, right? And a lot of them, majority in oncology, for Alzheimer and various sorts. And here, us, the owner of this raw material, are not making full use of it because we are fighting among ourselves, because we do not collaborate, do not cooperate, because we are too smart. Smart people tend to be suspicious, right? We tend to be suspicious. Oh, the fellow is going to steal my idea. The fellow is going to steal my idea. So don't work together. So you can't do anything, right? Because the system is poor in terms of the system of trust. How that system needs to be built so that researcher will know that they can share their knowledge without getting stolen. Yeah. So this is one of the first botanical drug, green tea extract. It was produced from green tea extract for prescription use of this what do you call it? This genital wart. You know, people have a lot of STD, sexually transmitted disease. So this green extract is approved. That means doctor can prescribe the drug without losing the license for genital wart. And you know how much per tube costs? $200 US, right? This one is another latex 1,3 for HIV-induced diarrhea, right? There's another one, but it was Amazon forest. They had some issues because they also had some poor understanding of supply chain. And now this is recently, past couple of years, this is based on cannabis-based product for seizure. Everybody know, I want to make ketum, I want to make cannabis. Yeah, but you need to do the clinical studies to show that cannabis is for this purpose. You think what? They're not going to allow you to approve the drug just for, stress, right? So, but then again, these things are coming. We all have to work together and bring our own botanical drugs and help to address that 54 million deaths every year, which can be used, is right in our backyard sometimes. So because it's thinking out of the box, right? Using that, I showed you the Swiss knife. There are many issues need to address. We need to work with different discipline. Okay, we need to work with engineers. Sorry, I moved to that. Yeah, we need to work with engineers. We need to work with people, agronomists. I remember us as pharmacologists so busy in the lab. And then when I needed my herb, I asked the farmer, I said, look, I need the herb for my plant, for my project. But can you plant it differently? Please don't put too much water, because the active compound is low. The farmer said, hey, I've been planting this herb for 30 years before you were born. You're telling me how to plant this herb? I said, yeah, I'm not, but this herb, I don't need to be lush green. I need to be like yellowish kind of. It's like stress. Only the active compound go up. The guy says, sorry, you go and fly kites. I don't want to do this. So I had to go and learn myself how to plant the herb. Then I sat down, understood what are the issues, what are the problems. But this shouldn't happen. If we had good collaboration, this problem would have been solved quite easily. Yeah. And then we have issues of manufacturing, large scale. We're trying to make in a particular way. So you have to speak with the engineers, to design your plant, your manufacturing facility. And also the other thing was, this is the biggest mistake we make as fundamental scientists. We don't speak to the clinicians, right? In the early phase, right? Okay, this is the dose I can give to the animals and stuff like that. And then, you need the, about 7-8 grams a day. And you go to the oncologist and say, okay, I want to give this much to the patients. 7 grams, how many capsules is that? Oh, it's about 30 capsules. You want to shove 30 capsules to cancer patients? They can't even swallow things. So really? Oh, I spent all the years making capsules, buying all these machines. Is that a waste? Well, it's not compatible. You have to think of something else. So we had to re-engineer again. So we made our product into drink, sachet, effervescence powder, and so on. But again, this should not have happened if the collaboration was done in the early phase. Again, regulatory, you speak to the regulatory, you should start speaking to the regulatory authorities in the early phase. You have to give feedback. We must lobby the regulatory authorities to accept our approach instead of them creating regulatory guideline out of thin air. Because there's no feedback, they will develop things based on what is out there, although may not be compatible to us. They need our feedback. So when we started this work, year 2007, one of the first things we did was we formed this Iman lab at School of Pharmacy, USM. The whole idea was Iman is a different concept where we have a working environment that foster collaboration between, so we have people from the engineering, physics department, chemistry, medical department, all working in the same lab, and we had so many different type of projects. We learned from each other. From this Iman, we collaborated with this Australian National University and this Australian Institute of Bioengineering and Nanotechnology to develop the platform for screening of our products. They were not doing herbal research. We were doing herbal research. We learned their platform. We modified for our use. And from there, our project started taking off. They provide the initial input. And it was very easy to go there. I mean, you go to the senior professor lab and say, okay, this is my office, this is my table, you can sit here, and very casual. But what we experience in our society is a bit different. It's very formal. So, I think Japan is really good. They go for their Japanese bath. After that, they can have a very good research collaboration. We need that kind of environment, perhaps go to the Nasi Kanda and build that relationship, and then, we can move forward. So we had this product, Nova Static. We have a display out there. It's targeting a particular process in tumor blood vessel development. And this was thanks to the John Curtin School of Medical Research, Australian National University. So I'll be talking a bit about it maybe today or tomorrow for this angiogenesis platform, which plays 70% of human diseases. We develop product that targets this pathway. There's so many products that got into the market, and we got about 3 products into clinical trial. So this was if you look at the project, it's you see this. First, we started off with computational simulation, working with some buddies from the computer science department, and how we do docking simulation to see the active ingredient of our product. Does it target this angiogenesis pathway? From knowing that, we can select which herb have the best effectiveness. And for our drug development strategy, we don't use the standard Western blot. You have to do one target at a time. That is for synthetic medicine. We use array platform, protein arrays. Put one compound, 100 targets, and then you can see whether it works or not. And then we breed these newt mice, and then we implant this tumor like nobody's business. This is colon cancer. You can see how the tumor shrunk because of as it shrinks, and we give the drug, the blood supply becomes less and less. The tumor didn't grow. And you see, this is we have this like a CT scan. It's a fluorescent, it's called fluorescent molecular topography. You can see this. We implant the tumor, and you can see the tumor is very active. And we give our extract, and you can see the tumor. You can't see the color anymore. So it has disappeared. And this is a drug in the market which costs about 15,000 ringgit per month for supply. And see, our drug is more effective. You can see there's no tumor growing here, and that. For that drug, the tumor is still active, but although it's a reduced form. So, and this one what we did, we thought, okay, let's try doing the conventional approach. Let's isolate out the active compound and test it. And guess what? See, there's still some growth there. So the extract in its entirety of other molecules present there was more effective than the single molecule. And here we dispel the myth of the magic bullet. Okay. So 2006, now 2022. Well, so we've, as I mentioned, we had to build an entire factory to do our toxicology studies from rats to dogs. And then we started doing human trials. So if we finished one trial in 2019 for cancer-related fatigue, because, 90% of cancer patients, they take chemo or even they have cancer, they suffer from fatigue, adverse side effect. So we tried that, and that study is successful. We have submitted to Lancet Oncology for publication. We hope we'll know by next month. And then at the same time now, we have entered phase 3 trial for end-stage breast and colon cancer. We combine also with chemotherapy because, the way the regulatory authority works, you can't just compare yours versus chemo like that. In the initial stage, you combine compared to your drug alone. So that one, 1,100 patients, we hope the study to finish by end of next year. And we just also finished a study on diabetic retinopathy. That one also was told is completed by just phase 2B studies. So I know my time is running up. I try to expedite. So this is, we were focusing only in this one plant, and using this extract, targeting this angiogenesis pathway, applying for various disease kind. So this is the cancer fatigue study which I mentioned. And, in the early phase, the good thing is, I said, herbal medicine, because when we produce our product, in the early phase, when the cancer patients from the hospital, the oncologists are giving their end-stage cancer patients who are not responding, when we gave them our drug, the patients within few days, instead of like lying in bed, they were walking about. It was not because the drug was that effective, but it was doing something that we didn't understand. It helps to remove their fatigue, their appetite improve. And more patients were coming, giving you that feedback. So we work with the clinicians. Hey, for this kind of phenomena, what kind of clinical study can we do? Oh, you can do asthenia. So how do we do these studies? Okay, we get this biostatistician and so on, develop the protocol. And then we did the trial. And it was successful, you see? Cancer fatigue, but we didn't go for anti-cancer yet. And that came later on because, you try with the low-hanging fruit. And then we started seeing patients who were end-stage given just 3 months to live. Even the oncologist was surprised. 2 months, they're still walking about. Hey, maybe your drug is working. So when we compile all the data, we present it to the ministry, say, look, this is potential, there's good scientific data, and this is the approach we want to do. And they fund our project. Okay. So this one, you can go clinicaltrial.gov. That is our Estina studies, which has been successful. We have submitted to US FDA for pre-IND meeting, and also submitted to the India Phytopharmaceutical and Malaysian regulatory authorities for Estina indication. And this is diabetic retinopathy, which mentioned, the study also completed phase 2. We still need to do phase 3. I was told the results have been successful. I have not seen the data. Next month, they'll give me the data. And also we did COVID-19. We did COVID-19 in the middle of the COVID-19 pandemic. Because when we did the Estina trial, the molecular, the array data and the computational simulation data showed that, hey, the active compound targets A2, the receptor, which the virus used to bind, to enter the body. And also, it targets interleukin-6, which is the inflammatory mediator, which causes oxidative stress, because people die of COVID-19 not because the virus killing you, it's your immune system attacking you. So, and while we were sitting in the computer around the world with all the researchers doing simulation and get some labs to do some validation, one of the trial sites in India, they were doing clinical studies for our diabetic retinopathy. We said, look, can you get permission for us to do COVID-19 study on severe, moderate to severe COVID-19 patients who are on oxygen support? And we all wrote all the documents and submitted for ethics approval. So we got approval to do 10 subjects, but placebo control, 5. And the results came out within 3 months. It was shocking. The results was really good. And it shows that although a small group, it shows the patient recovered within 3 days. Then we submitted to the Malaysian regulatory authorities. We wanted to do trial in Malaysia. But unfortunately, what happened was all the principal investigators, they said, look, we are so busy in the hospital, we don't have time to do this trial. I said, but you got trials to do, you got time to do those vaccines and stuff like that. Oh, sorry, but because in reality, they don't have confidence of herb because they think it's herb. They don't want the botanical. Even when we wanted to do the phase 3 trial in Malaysia for the cancer trial, 90% of the oncologists in Malaysia rejected because they think it's herb, right? So we have to do it overseas. So regulatory say okay, authorities say okay, but the perception. So this is other challenge that we have. Okay, so this is the COVID-19 studies. So this is our manufacturing facility. Our facility is unique whereby next to our factory, we breed mice. We take out rats, organs, tissues, and part of our quality control to test the effect of our drug. And then we also had this problem, seasonal variation. When the plantation region that we're using, only 6 months you can use, other 6 months you can't use. And the farmer complained, hey, I don't have Bangla workers to come and help me to plant these herbs, and it's too hot. Our locals don't want this. So what did we do? In our backyard, through YouTube, you learn how to make this, right? This was started off from my backyard, from YouTube. I made a small, simple one, and then test sent to the lab and saw the active compound was good. Then we did a pilot scale, and 1 acre of this can produce equivalent to 100 acre, right? And increase productivity. You can employ graduates and, to produce this product. So generally, I'm just going to summarize. Herbal drug research is generally more affordable, but you have to be smart. How you have to do research. You have to think like doing business with a limited amount of money, right? It's more democratic, benefit the farmers, benefits the end users. And, we reduce dependency in importing drugs. And when we didn't have those vaccines and drugs, our country could have produced our own drugs. Other countries, Thailand and so on, they had their own herbs available for these diseases. So reduce our imports. Yeah. So again, challenge raw material, regulatory restriction, because they're still learning. Everybody's still learning. I'm still learning. And we need strong scientific data. And we need to be able to work collectively in terms of how to develop this, because it is a challenge. It's not easy. I would like to thank you very much for listening to me. Thank you very much.
Okay, thank you. Thank you, Dr. Amin. Please remain on stage. We can afford a few questions. So I shall open the Q&A to the floor. Anyone? Is there a microphone for the participant? Yeah.
I'm going to take a selfie if you don't mind. I have to prove to my wife that I'm here. Sabahan wife quite challenging.
Oh, I'm a Sabahan too.
Oh, sorry.
Okay, you'll find whether my question is challenging, okay? Thank you, Dr. Amin, for the very interesting presentation.
Okay.
So I was intrigued by your statement that you say oncologists don't really want to use herbs in treating their cancer patients. This is what I think would supplement the reason why they are not using, but of course, I'm seeking your opinion. Do you think it is more about not getting enough incentives from the big pharmaceutical company to push certain drugs? Because I accompany my husband to go to the skin doctor in SGH. So I think each time when we go, there's always a drug pusher there. Drug pusher as in rep from big pharma, pushing certain drugs to the doctors. So I'm sure there is some sort of financial incentive that is given to these doctors to use certain medication from big pharma. So do you think this is also one of the reasons why oncologists, on top of the list of reasons that you have presented just now, that actually deter doctors from using botanical-based products?
I can't really say for sure because we are paying them money. Okay, we're not talking about small amount of money, it's millions of dollars. But the thing is, if you're in a government hospital, I mean, your salary is still going to be the same, right? Only your workload is going to increase. So that was one of the major feedback that I used to get, that they don't have time. But then the next thing is I see them agreeing to do a study from a big pharma. Is there something going in the background? I do not know. I'm not familiar with this kind of arrangement. But again, I would probably think that it may be similar thing that what I went through in the beginning, 15 or 20 years ago. I was doing synthetic drug research. To work in herb is not cool. And, you know, there are a lot of things I didn't know about. And so maybe sometimes, you know, it may tarnish reputation. If you say, oh yeah, the oncologist is doing herbs. So I'm not sure. I really have no idea. Yeah.
Okay,
But private hospital has agreed. We have only one private hospital, you know, Mahkota Pahang. They have agreed to participate in our trial in Malaysia. So, but the others, we tried HKL, Penang, GH. We had Magna Cancer Hospital. I mean, our cancer IKM Institute Cancer Negara. No interest.
Okay.
Yeah.
I have another question based on the slide that you showed just now on your research progress. So my question is, generally, how long does it take from the moment you start your research all the way to commercialization for the product to be used by oncologists or being on the shelf of pharmacists and so on, based on perhaps past experience or research that others have done? How long is the timeline?
Well, you see, because we were doing this in the beginning, so we went through the long route. It's like flying here to Australia. Instead of flying here directly to Australia, you go to London first, and then you come back that side. So our first drug, this Novastatic for the cancer asthenia, I think took us almost 10 years. Yeah, 10 years. But the diabetic retinopathy studies, we managed to jump from within 3 years, we finished phase 2 studies.
Okay.
Right? Because what we did was the safety data that we used for our first product, we used that one again for this indication. But then again, you know, They want you to do, if you want to get ethics approval, you have to show some kind of animal model efficacy. So we can't go to the university and knock on the door and then the supervisor, the lecturer say, oh, I need to recruit a PhD student, going to take 3-4 years. So we build our own facility and we have the animal data within 6 months, you know, and research was much faster.
Okay.
So if you're doing commercial, you have to think of a commercial way. So, but you know, if you're doing for free, like grant based, you know, that one take longer.
Okay, thank you. It's not very challenging, right? Sabahan wife.
Before I could marry my wife, I had to climb up Mount Kinabalu, show the
that's-
color certificate to my father-in-law first.
That's sure, for sure. Well done. Thank you.
Thank you.
Can take 2 to 3 more questions. Anyone? Yeah, come.
Thank you. I appreciate with your interesting presentation, Dr. Amin.
Thank you.
This is quite long route for you, I think, because there is, from my perspective, there is 4 challenging that you have faced from the herbal itself. You have to keep the quality and also the, how can I say, consistency of the raw material. And the second one about the regulatory from the, how can I say, government, and from the human itself about the mind perspective about the herb to be drugged, and the last one about the limitation of the budget. So this is really, how can I say, strong motivation for everybody. So my question is, how do you make a deal with the limitation resource of fund or something like that? Thank you.
Okay, sorry, could you repeat the last question? Sorry.
How do you deal with the limitation budget that you have?
Oh, the thing is, don't make money as your object. Okay, you have to be, I said, passionate, in love. You know, love is blind. So you have to be in love. You have to be blinded by love. Money doesn't matter, right? So, and of course, you know, people say young people get married young because you're still not very smart. You're in love. Love is blind. You get married, and then you say, "Oh my God, it costs so much money." It's the passion. Okay. I didn't want to do this kind of work. I tell you frankly, when the product showed to be effective in the cancer patient, I was telling some of my colleagues, it became a moral obligation. I mean, yeah, you get all the gold medals, publications, you can get everything, but to go this path, you have to look yourself in the mirror. Is it all about medals and publications and impact factors and stuff like that? And where you can see people benefit. Just last week, the first patient who used this drug, 12 years ago, she had breast cancer with multiple bone metastases, called me saying, "Hey, how are you?" You know, she wanted to come and visit. I mean, this is the greatest pleasure you get, more than money. And you see their children, young age, people come overseas, but we cannot advertise. That's the difference, right? But the reward you get, the personal benefit, the personal reward is the greatest. Money-wise, you lose more, you know. I mean, when I had to put a point, I had to put a stop, because I was in the university, there's a lot of conflict of interest. You have to leave, take a pay cut, 2/3 pay cut, you know. But the benefit you feel is much better. You see these patients and you're making a change in the world. So that is the passion that we need to have. And, you know, that is your drive. When you put that as your priority, and things will come. If your passion is more money, yeah, we'll get money, but that's all about it. Yeah. So grants, every grant. So what we did was, the major challenge I had was working collaboration. As I mentioned just now, we as scientists, we are very smart, so smart, we are suspicious, and that's how we make discovery. But then we become suspicious of our colleagues, right? And then if one colleague published paper, they didn't put your name, and that's it. And that's the end of research. You must understand, research is like, as I said, like, you know, it's like a building a computer. You build a computer, you have your CPU, you have RAM, your power supply, you have all the transistors and stuff like that. They all sit on a plain motherboard. And if you look at the motherboard, as I say, the wiring system is trying to accommodate everybody. You may have the best CPU, best hardware, but if it's not connected, no software, it doesn't work. So how to make people work in collaboration? So my inspiration, at one point I wanted to give up. At one point I wanted to give up because it's challenging. And back in 2007, 2008, there was, how to make these people work together. So, and then I listened to a talk, how the Prophet Muhammad, peace be upon him, managed to unite the warring tribes of Saudi Arabia. Oh, not Saudi Arabia, warring tribes of Arabia. How he made them work together, unite. So like when people did bad things to them, he repaid in kindness. And his enemies became his allies. And we worked together. So that's why I formed a lab called Iman, means trust, faith. So it doesn't matter what race, religion, whatever, we put a system in place whereby everybody can come and work in a good environment. We used to go hiking together, do all kinds of things. When we did our PhD in all Western countries, they'll do all these social activities. We think, Allah, waste time only. But this is very important. We need to spend more time with each other to remove that doubt and suspicion. And we can work together and understand that common language. And then we can move forward. So this is as important as your laboratory work. Yeah, I think, we need to understand that. Yeah, thank you.
Okay, thank you. So Dr. Ami, I have questions about you're advocating the polymolecular botanical medicines. So I think it's very good for cancer because there are multiple molecular targets that you wish to use multiple molecules to target them, right? Now, however, through omics analysis, sometimes we may realize that the cancer patients may not have that target, or that target is not responsible for his or her cancer. So on this note, administering polymolecular botanical medicines, a lot of therapeutic in there actually go to waste. So can you comment on that? Yeah.
Okay. When I say polymolecular, but when you're speaking the pharmaceutical, regulatory, or clinician, it's a different language. Ours, we call it standardized extract. That means we know the active compound, but we don't isolate it. When we produce our plant, we show before they harvest, we check for that rosmarinic acid active compound. And when we do our quality control, after we produce the batch, the rosmarinic acid compound. What is it? When you do a human clinical study, pharmacokinetic study, we check the plasma, where's the rosmarinic compound? How long does it last in the body? Because when you create the clinical trial protocol, they ask what is the dosing frequency? How many hours? And based on what justification you need to provide that. But in terms of mechanism, we look at this angiogenesis mechanism, process of new blood vessel development, which plays critical role in almost all of human cancer, right? It is not cytotoxic. It doesn't kill the cancer cell. So if you do cancer research, you look for the general cytotoxicity, i.e. killing the cancer cell. You put this on the cancer cell, it doesn't kill the cancer cell. But if you put in a tumor environment, yes, it will starve the tumor. So this drug is, based on our hypothesis, may be effective for all type of cancer, right? But the funding is only for breast and colon cancer and cancer fatigue. Why we did the cancer fatigue? Because we know that we will not be able to do all the research for different type of cancer, but we target a common factor that affect all cancer patients. We just say, okay, fatigue, cancer fatigue. So it doesn't matter what cancer you're having, it will benefit you, but I'm not going to tell you that it's going to cure or prolong your life for this particular purpose. But I know that you will see, your oncologist will see that there's going to be either slowing down progression or stop on progression or tumor regression. And then you deal with that later on. Let's say now we see that it's good for lung cancer, right? Okay, there's some case studies coming out, and then we find researcher, hey, can you apply for grant? Yeah, to do this grant. Or you do a business proposal. Okay, I'm going to license off this one, and then to give you a license for lung cancer. You have to do that. There are many ways, but we need to learn to speak to people, attend conferences. And the problem is in Kuching, you're far away. We were in Penang, we were far away. I mean, to KL, you have to attend the conference, many conferences. But your dean will be worrying, where are you? You're supposed to be teaching, right? So no, we have to be there. So this is some of the things, the issues that you can deal with.
Just one last short questions. Now, in the slide earlier, I think it shows that the extract is better than the isolated active, right? Because they eradicate the cancer totally. So in other words, there may be some small little ingredients that interact with the active, making the extracts better. However, there's no standardization with respect to this small little so-called unknown compound. So what will be the risk of inconsistent quality? Because the plant is from the nature, right? So we can't really control whether this small little amount of ingredients will be there consistently.
Yeah, we use a method called FTIR, fingerprinting. So the chemical fingerprinting that shows for all that's inside there. Even if you change the plant, same plant from a different plantation, the fingerprint will be different.
But the FTIR, it will not be able to detect a small quantity. And most of the compound, they have the same functional group, OH, CH, NH, C double bond O, CO. So the FTIR may not be a very good technique to identify.
Yeah, there are many things, but for this requirement, you know, I mean, you say when we do our studies, there are three things we do. One, HPLC, show the active compound how many percent.
Okay.
2, FTIR, fingerprint. 3, a biological assay. The biological assay is robust enough, which we have validated to show that whatever composition change, that it will affect that our angiogenesis activity. And that is a requirement for a US botanical drug. You must have analytical plus a relevant biological assay for every manufacturing batch.
Okay, noted. So with that, let's put our hand together to thank Dr. Amin again.
Thank you. Thank you.
Thank you very much to Dr. Amin Malik Shah and Professor Dr. Wong Tin Wui for the keynote session. Ladies and gentlemen, I would like to invite Associate Professor Chemist Dr. Muhammad Isa Mohammadin, accompanied by Professor Kong Heng Yen, to be on stage to present a memento of appreciation to both our keynote speaker and moderator. First, I would like to invite Dr. Amin Malik Shah bin Abdul Majid, Chairman of Iman Medical Research Australia. Next, I would like to invite the chairperson, Professor Dr. Wong Tin Wui. You may return to your seats. Ladies and gentlemen, that wraps up the first half of our conference. Lunch is provided at Hall B, and the afternoon session will begin at 2:15 p.m. Thank you.
This is a new horizon. we'd never imagined. In a land as old as time lies the ancient wisdom of mankind. We are all in search of something greater to find meaning in the mysteries long forgotten. What if we went back to where it all began and reconnect with our origin? Now feel the rhythm of Sarawak. This is our prayer for the world. May you come alive even in the stillness as you awaken to newfound senses. May this life be a more immersive journey for as far as you wander. Sarawak, your journey begins here.
Wendy，你的货到了，请签收一下。
安哥，这么晚了还来，真的是麻烦你了。
哎呦，没事啦。
这样我去拿一支笔。
好好好。
安哥，你来这里那么多次，我都没带你看过这个地方，不如我带你去看看？
好啊，好啊，好啊。你是本地人吗？
我是啊，几年前才从伦敦回来的。
哦，那你回来做什么？像你们这些搞艺术的，在外地不是比较有前途吗？
在外地当然好啊，大城市有很多创新发展的空间，但这是我的家。过去我以为要到世界里头去才能找到自己，却不曾想，婆罗洲里也有一群很有潜能、很棒的一群人。现在我相信，即使回家，我们也能够与世界对话。
Sikit je kami dah teguk ni. Toklah Sarawak. Kita mesti pandai berenang. Mesti abang. Bagi kami, lebih senang lagi berenang daripada berjalan. Boleh. Sejak kecil, kami dah biasa dengan kehidupan macam tu.
Tak orang stok ke?
Tahu, kami orang situ. Tapi, dah lama si balik tu. Dulu kami sekolah di asrama. Dikialah tempat kami belajar berenang.
Kita pergi sini tu.
Kami mau balik tu. Mau jumpa anak kami. Dah lama si bertemu dengannya. Rindu rasa hati tu. Suatu hari kelak, kami mau mengajar anak kami berenang. Itulah kampung kami. Pagi ya. Raja. Ayah.
Take you by wonder, listen closely. The sounds of the rivers call for you, and the rainforest too. Here is where legends come alive and cultures thrive. Here is our paradise. Of our soil, like pieces of gold. There's more in the mountains and seas. There's more
Prof, I'm leaving now.
Oh, don't forget the headlamps.
I'll see you soon.
This is our 46th trip to the Penderson site, and our funding to find the lost frog has run out. It's Ansonia minuta.
We're not gonna find it. Seems like we've been finding for this frog forever.
You know what the indigenous people say? That you must never tell the forest what you're looking for, or you'll never find it. Come, let's take a break.
Oh, thanks, Prof.
Sarawak is so amazing. Every time I come to these rainforests, I learn something completely new. Growing up as a boy in Calcutta, I could have never realized I would have been spending time here in the rainforest, teaching, researching, learning new things. You are born here. You're so lucky to be in the midst of such biodiversity. It takes many small steps to make a big discovery.
Do you hear that, Prof?
Yeah, that's unusual.
Beautiful.
Yes, and has all the colors of the rainbow.
Why do we need to go so far? The mountain, a thirst to reach the peak, gazing beyond the waterfall, a desire to seek its source, a deeper exploration of the sea, to be in love with fear and become fearless. Why must we witness, hearing the stories of another tribe, seeing their legends with our own eyes, echoing the longing of my heart? Yet it's as if I am home. Why do we want to be here, taking a deep breath of foreign air? Only when you feel it yourself have you lived, finding peace in the hustle and bustle of life, enriching hungry palates. Why leave our trace? The wonderland you seek will be a huge one. All has has been prepared here for you centuries ago. One's destination is never a place, but new ways of seeing things. Why limit yourself?
as I feel, it wouldn't be the same. Some things are not spoken of, some things have no name. Though the words come hard to me, I'll say them just for you. For this is something rare for me. This feeling is so new. You see, I love the way you love me. I love the way you smile at me. I love the way we live this life again. Long ago I heard the song that lovers sing to me, and through the days with each new phrase I hum that melody. And all along I love the song, but I never learned it through. But since the day you came along, I've saved it just for you. You see, I love the way you love me. I love the way you smile at me. I love the way we live this life again. I don't believe in magic, but I do believe in you. And when you say you believe in me, there's so much magic I can do. Now you see me, now you don't. Watch me dive below, deep down in your love lake where the sweet fish come and go. And I might sink and I might drown, but death don't mean a thing. 'Cause life continues, right or wrong. When I play this birthday song, I learned from you, and you can't even see. There's something I want to tell you. There's something I think that you should know. It's not that I shouldn't really love you. Let's take it slow. When we get to know each other, and we're both feeling much stronger, then let's try to talk it over. Let's wait a while longer. Let's wait a while before it's too late. Let's wait a while before we go too far. Remember that special night when all of the stars were shining bright. We made our first endeavor to stay together. We made our very first promise to love, to share, and be real honest. But on that very first night, it wasn't quite right.
Can't take my eyes off you. You'd be like heaven to touch. I wanna hold you so much.
At long last, love has arrived, and I thank God I'm alive. You're just too good to be true. Can't take my eyes off you.
Pardon the way that I stare. There's nothing else to compare. The sight of you leaves me weak. There are no words left to speak.
But if you feel like I feel, please let me know that it's real. You're just too good to be true. Can't take my eyes off you.
I love you, baby, and if it's quite alright, I need you, baby, to warm a lonely night. I love you, baby, trust in me when I say, oh, pretty baby, don't bring me down, I pray. Oh, pretty baby, now that I found you, stay and let me love you, baby, let me love you.
You're just too good to be true.
Can't take my eyes over you. You'd be like heaven to touch. I wanna hold you so much.
At long last, love has arrived, and I thank God I'm alive. You're just too good to be true. Can't take my eyes off you.
I love you, baby, and if it's quite alright, I need you, baby, to warm a lonely night. I love you, baby, trust in me when I say, I love you, baby, and if it's quite alright, I need you, baby, to warm a lonely night. I love you, baby, trust in me when I say, oh, pretty baby, don't bring me down, I pray. Oh, pretty baby, now that I found you, stay and let me love you. I love you.
breaking up is hard to do. Now I know that it's true. Don't say that this is the end. Instead of breaking up, I wish that we were making up again. I beg of you, don't say goodbye. Can we give our love
tepat mong kahit monyo ayon sa ayon takut tepat mong
Ladies and gentlemen, before we begin, could you please fill in the seats in the front row? Please fill the seat at the front row. Thank you. We are just waiting for one more panelist, so make yourself comfortable in the meantime. So, wait. Dear InnoSTRE delegates, welcome. Welcome to InnoSTRE Forum. Associate Professor Dr. Hasmah Mohidin, Assistant Rector UiTM Samarahan Campus 2, representing Yang Berbahagia, Professor Dato Dr. Jamil Hamali, Rector of UiTM Sarawak. Professor Kong Heng Yen, Co-Chair of InnoSTRE 2002. Mr. Gu Liang, Director of International Cooperation, Ma'an Shan Teachers College University, who is joining us virtually. Professor Technologist Wong Tin Hui, Chair of Pharmaceutical and Nutraceutical Innovations Forum. The forum panelists, conference participants, ladies and gentlemen. We are lucky today to be graced by the Zoom presence of Professor Dr. Lu Xiong-Ren, Vice President of Anhui Medical University, China. Without further ado, I invite Professor Dr. Lu to deliver the opening remarks. Prof, the virtual floor is yours.
《
Thank Yes, Prof, can you hear us?
Professor, can you hear us?
We are ready
Can you
for
hear
your
us?
opening remarks. The floor is yours.
Professor, we need to share our screen to show the video. Could you please
A few
allow
minutes,
us?
yeah, ladies and gentlemen. Oh, I believe she wants to show a video, yeah. All right, Prof, we're trying to show the video that you requested.
Thank you. And please wait a minute.
A few hiccups, right? It's always happen in virtual conferences, so please bear with us. All right, at this moment, we are waiting for their sites from Anhui Medical University, China, to fix some of the technical issues. Because they have been appointed as the co-hosts, right? Prof. Zhang, could you please say a few words? Unmute yourself first so that we can hear from you. No response. Can you hear me, Prof. Zhang? Hello, Prof. Zhang?
尊敬的马拉工业大学的各位领导，尊敬的王教授、孔教授，尊敬的各位专家、各位来宾，大家好。首先，我仅代表安徽医科大学对此次盛会的成功召开表示热烈的祝贺，向主办方马拉工业大学以及会议的组织者表示衷心的感谢。这是我们药学学科和马拉工业大学的同行们第3次合作举办药学国际学术论坛。今年又特邀了很多知名专家、学术大腕，我们期待着专家们的精彩报告和分享。我校的药学学科发展历史悠久，科研实力较强，一直是学校的优势学科之一，也是国内抗炎免疫药理学和临床药理学的创始单位之一，拥有抗炎免疫药物教育部重点实验室，并正在筹建省部共建炎症免疫系疾病国家重点实验室。药理学与毒理学连续7年全球排名一直位于 ESI 前1%。我们非常期待各位专家将来访问我校，共同合作。最后，祝本次论坛圆满成功，祝各位嘉宾和朋友们身体健康。
Apparently, we're losing the audio, so yeah, just the video.
Professor,
but Prof. Zhang, can you hear me?
Professor, can you hear
Prof,
me?
how are you? 你好吗?
Professor, can you hear my voice? And I will translate Professor Liu's speech briefly. And
we'll just have to be patient. Yeah, it's a little bit tricky when you do hybrid conferences.
All the
Technical issues
distinguished
might appear.
directors, experts, and guests, good afternoon. First of all, on behalf of Anhui Medical University, I would like to extend my warm congratulations on the successful opening of the event. And thanks for our partner and the conference organizers. This is the third cooperation of our universities to hold an international academic forum. This year, many famous experts are invited, and we look forward to the excellent reports and sharing from experts. The pharmacy discipline of our university has a long history and strong scientific research capacities. It has always been one of the best disciplines of the university, and it is also one of the founding units of anti-inflammatory immune pharmacology and clinical pharmacology in China. It has many research platforms, such as key laboratory of the Ministry of Education. And the pharmacology and toxicology has been ranked in the top 1% of ESI ranking. We are looking forward to your visits to our university and cooperation in the future. Finally, I hope this forum a complete success, and I wish all the guests and friends good health, smooth career, and all the best. Professor, can we move on?
All right, due to unforeseen circumstances, we're going to continue with the forum first. So I would like to invite the forum chair of the conference, which is Professor Technologist Wong Tin Hui. There will be 7 distinguished invited speakers. Some will be joining us online. One is here physically, who will share their expertise and experience in fields related to InnoSTRE. Therefore, without further ado, I invite Professor Technologist Wong Tin Hui to chair the forum. Prof, the floor is yours.
Hello. Yeah, thank you. So I think this year the InnoSTRE's 2022 forum. So we will focus on how to succeed pharmaceutical and nutraceutical innovations for the betterment of society, right? So this afternoon we are going to brainstorm about challenges and approaches, to commercialize or to have a better evidence-based data for pharmaceutical and nutraceutical innovations. Me and Professor Meng Xiaoming from Anhui Medical University, China, will be chairing. So I wish to know if Professor Meng is over the other side.
Yes, Professor Kong. Everyone, hello. Yeah, I'm here.
Hi, Professor Meng.
Yeah,
so,
hello.
Welcome to the InnoSTRE, right? So this afternoon we have 7 experts from China, Russia, United Kingdom, Malaysia, as well as Australia, right?
All right.
Professor Meng, yeah, perhaps you would like to highlight about the content and objective of today's forum.
Okay, thank you, Professor Kong. Yeah. I also, I'd like to, today we have invited 7 outstanding speakers. Some of them are very famous scientists in China. I have briefly reviewed the titles of their talk. It is very comprehensive and interesting, ranging from the basic research to the clinical application. Professor Wei Wei will give us a talk regarding discovery and development of new drugs from nature medicine. Professor Rafalski will share an advanced technique called pharmacophytonics with us. Professor Botoka will show her critical insight into in vitro in vivo relationship in pharmaceutical innovation development. Professor Yizhun Zhu will lead us to know drug discovery of novel compounds, bench from Basset. Dr. Chen Haiyong will talk about his research regarding natural products on diabetic kidney disease. Mr. Qinglao Hongqing will give us a talk on precision herbal medicine for primary patient care. Dr. Majid will talk about angiogenesis targeting botanical drug development, a successful platform in botanical medicine drug discovery. I think these topics are very attractive and interesting. Professor Kong, I think we should give more time to the speakers. Could we begin now?
All right, thank you, Professor Meng. So overall,
thank you.
I think today we will be looking at how to translate the innovation from bench to clinical and into commercializations. And if you look at the topics today, we are actually geared towards personalized therapies or precision medicines and therapeutics. So without further ado, let's welcome Professor Wei Wei from Anhui Medical University, China, to share his presentation on discovery and development of new drug from natural medicines. So Prof. Wei Wei, the stage is yours.
Okay. 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 Can you hear the point?
Yeah.
PowerPoint not yet.
Yeah. Can you hear the PPT?
Perhaps you need to share screen.
Thank you, Professor Kong and Professor Mun, for your hosting and introduction. Good afternoon, ladies and gentlemen. I'm Wei Wei from Institute of Clinical Pharmacology of Anhui Medical University, China. I'm very glad to attend this forum and be invited to make speak.
Yeah, Professor Wei, we couldn't see your PPT.
Okay.
The share button is at the lower bottom, green color.
Yeah. Can you hear?
Yes.
Can you hear?
Yes, we can hear you and we can see your PowerPoint. Thank you.
Okay, thank you. Yeah, good afternoon, ladies and gentlemen. I'm Wei Wei from Institute of Clinical Pharmacology, Anhui Medical University, China. I'm very glad to attend this forum and be invited to make speech. The title is The Discovery and the Development of New Drug from the Natural Medicine, Soft Regulation of Inflammatory Immune Responses. The contents includes the two parts: research ideas of innovative drugs from natural medicine, and give an example in our team from pure onion, total glucose size of pure onion to CP25. As we know, natural products refers to various substances found in the nature, including the plant, minus animals, microorganisms. And the natural medicine, which is the medicine made from the natural products used to prevent and treat disease. The discovery, collection, use, and the proceeding of natural medicine and treatment of disease run through the whole history of the human beings. In the Ming Dynasty, Li Chuan, as Chinese, introduced the organic acid was obtained from Chinese, the golem buff, the fermentations. The organic acid, the first organic acid obtained from the natural products in the world. After establishment of the modern scientific systems, the study of the natural products focus on isolate and identify active compounds, such as in the 1806, the German pharmacy, the first isolate the monomer compounds from opiate therapy, that is morphine, morphine for analgesic in dog. With the development of organic and medicinal chemistry, artificial synthetic, the small molecule is increasing the dominant. To modify the structure of natural products are still one of important mirrors of new drug discovery and development. What's innovation drug? I think including the 4 levels, the first and the second levels, that means to discover the new target and the new compounds, which belong to the original innovations. The third and the fourth, that belong to the track the innovations, which is a no target for the new structure types. The core of innovative medicine is the innovation of new drug and new mechanism and the guidance of clinical demand. Functional, genomic, and proteomic research is needed to discover new mechanisms of disease, develop new lead compounds based on the traditional treatment experience of the natural medicine, and carry out the pre-clinical and clinical studies and come into the market. What's the efficacy target, which refers to the biologic macromolecule directly bound to drug and produce the therapeutic effects. At least drug target is limited. So far, there are only over 900 targets, over 1,600 drugs. There are 4 family dominated targets, including GPCR, IO channel, protein kinase, and nuclear receptors. The effective targets for small molecule drug account for 70%. In the past 20 years, anti-tumor drugs and immunosuppressant has been developed and marketed actively. The common research methods, including the targeted discovery method for small molecular market, such as biotin, the correct reactions, and second, and laboratory targeted discovery method for small molecules, such as drug affinity responsive target stability, the cell service shift RC, and the TPP, the CRISPR-Cas9, and MST, ITC, SPR, and so on. It's a very important method to find the new compounds and the new mechanism. From the clinical application of aspirin in 1989 to the present, we can see the history of the mankind's structure in small molecule drug research. This is the example for the small molecular discovery and the clinical applications. The new model in present, including the target covalent inhibitors, PPI, the protein-protein interaction, RNA target small molecular, antibody drug conjugate, the protein, the nitric, and the molecule genus InnoSTRE. This is my tutor, Professor Xu, introduced the relationship between inflammation and immune responses, and create the anti-inflammatory and immunopharmacology. In the body, about anti-inflammatory and immunopharmacology are introduced the basic concept, the basic receptor, research content, research method, and the progress of about the anti-inflammatory and immunopharmacology. And this theory guided the TGP NDA market in 1998 for rheumatoid arthritis, which produced the significant science and economic benefit. According to the efficacy and the safety, especially the imbalance of the efficacy and the safety of the drug, I introduce the new theory about the soft regulation of inflammatory immune responses, and to guide the creating of CP25, obtained the Chinese invasion patent and the PCT patent in European, Japan, and Australia, and so on. As we know, Peonal lactifloria is derived from the root of the cultivate the Peonal lactifloria. As early as the Eastern Han Dynasty, there was the history of the traditional Chinese medicine plant proceeding in magment of the Bozhou, Anhui province, China. Total glucoside, that is TGP, is an effective part extracted from the peroneal lactifloria, mainly containing peroneal, oxyperoneal floria, and so on. TGP has anti-inflammation and immunoregulatory effects for the treatment of autoimmune disease, such as rheumatoid arthritis, SLE, and so on. Peroneal floria is main component, also has the similar effects. However, the bioavailability is low and the molecular mechanism is unclear. Also, PA works by modulate the cell GPCR signaling. How it does so is not known. Due to our long-term research on active these compounds, the chief editor of the Pharmacology and Therapeutic invited me to write the review, which introduced the pharmacological action, mechanism, and the clinical applications of TGP and PAE. CP25 is the PAE6 plus oxygen, the benzogen sulfonate. It has good bioavailability and safety, and more strong pharmacological action. It has the cyclohexane and derived structure, which may inhibit G protein copper receptor, the kinase 2 activity. Sorry. Okay. JAK2 is interlinked with multiple molecules and playing the core role in regulating cellular physiological activity. Abnormal changes in the several diseases such as hypertension, heart failure, AD, diabetes, cancer, RA, and so on are pathophysiology basis. No new drug target JAK2 has to be marketed. We study the role of JAK2 in disease and the target effects of CP25. The aim to find new targets and the new compounds. Our team found the expression of JAK2 and PG2 in synovial of the rheumatoid arthritis patients was abnormal. CP25 improved the abnormal expression of GRK2 and the PG2 in the synovial memory of the animal model, the plan a treatment action. And also we found that CP25 destroyed abnormal the GRK2 mediated the PG2 signal transduction in synovial cells and improved the malignant proliferation of this cell. It was found CP25 combined GRK2 and can inhibit activity of GRK2, the by MSTIC and ADP glucokinase acids and so on. The further study results showed that allegiance of GRK2 may binding site of CP25. We were also invited to present the new progress of this compound's research in ACTA Pharmacologic Sinica. The memory of the research nomenclatures of the drug classification of International Union for Basic and Clinical Pharmacology, the NCRU, that concede the CP25 regulate its activity for targeting the GRK2s to destroy the normal single transduction of prostaglandin receptors, the one of the subtype, the AP4, which is new drug classification world exploring and will provide the direction for the development of new target drugs from natural medicine. Inflammatory immunoresponses has similar function of activity changes in the variety of cell and molecule. Abnormal inflammatory immunoresponses is a passive physiological basis of many diseases. Regulating the balance of the key molecular activities involved in inflammatory immunoresponses cell signal transduction, that is soft regulation of inflammatory immunoresponses. And the driving the pathology to return to physiology is very important pharmacological basis for the development of new drug and the rational drug use for inflammatory and immuno-related disease.
Okay, Prof, perhaps you would like to summarize. Okay.
Yeah, in summary, the ancient times and ancient and scientists has provided the abundance refers for us in the development and the clinical application of natural medicines. The vast land and the deep sea give birth to inhabitable resources, and the protection and cultivation of the contemporary people provide the rise to chairs. The nature harmony, the body balance, and natural medications, the right drug has to be advantage in driving the pathology to play in the soft regulation role in the physiology discovery. So we must study hard, strive to explore, and work hard to create. Thanks to teachers and students of our terms, thanks to the NSFC key and general project supports. Thank you for your attention. Thank you.
Thank you, Prof. Wei. Yeah, Prof. Wei will leave the question and answer sessions to the last slot. Yeah, so do bear with us. Prof.
Mhm.
Yeah.
Thank you.
Is Prof. Meng here? Okay, if not, our next panels is Professor Rafalski from Russia. So he will share with us on pharmacoproteomics, a possible alternative to omics technologies in personalized pharmacotherapy.
Okay. Dear Dr. Wong, dear Dr. Mann, thank you for introduction. Good afternoon, ladies and gentlemen, dear colleagues. First of all, on behalf of Rector and staff of Kant Baltic Federal University, I would like to thank the organizing committee of the InnoSTRE 2022 forum for the invitation and pleasure of sharing the result of our research. Allow me to introduce myself. I'm Vladimir Rafalsky, MD, Professor of Medical Institute and Director of Clinical Trials Center in Kant Baltic Federal University, Kaliningrad City. My primary medical specialty is clinical pharmacology. In my presentation, I would like to talk about some findings made by our interdisciplinary team of scientists at Kant Baltic Federal University. I'm honored to present some of the scientific results of our scientific team in the last 3 years by our research team. A special feature of our scientific team is the involvement of scientists from different fields of science, in particular cardiologists, clinical pharmacologists, optic, physics, chemists, material scientists, biologists, and data processing specialists. Next slide, please. Okay. However, at the beginning of my presentation, I'd like to say a few words about personalized pharmacotherapy to make sure that this field of medicine and pharmacology is one of the most actual at present. We can search the scientific literature using keywords, personalized pharmacotherapy. You can see that the number of publications is growing all the time. Another important indicator of the relevance of this field is the increasing number of newly registered drugs prescribed using personalized medicine approaches. You can see on the slide that the number of such registered medicines has increased dramatically in the last 5 years. In my opinion, a concept of biomarker plays a central role in a conception of personalized therapy, in personalized therapy algorithm at the present time. A biomarker is a measurable indicator of some biological state or condition. Depending on the research approach used, there are a large number of biomarkers. In pharmacogenomic studies, for example, certain features of genome or genetic polymorphism are used as a biomarkers. Different biomarkers detection technology are often described by the general terms, omics technologies. There are currently hundreds of such omics technologies developed. Today, however, scientists and physicians often ask the question, can the large number of omic technologies developed today fully solve the problem of individualization drug prescription? The answer to this question is probably still no. This negative response can be explained by the presence of several significant limitations that classic omics technologies have. Each omics studies a relatively narrow part of cell or tissue function. The problem is that we can relatively easily carry out a study using one omics technology, but it is very difficult to gather information using several omics technology at the same time for one patient. This is due to the technical challenges, such as using different biological samples, different sample preparation protocols, and different laboratory equipment for different omics technologies. In addition to implement different omics technologies, scientists with different backgrounds and specialization are needed. This problem complicates research using several omics technology at the same time. An important factor is that the cost of such research is quite high. Are there any alternatives to omics technology in the field of personalized medicine, personalized pharmacotherapy? A possible alternative could be pharmacophotonics. Pharmacophotonics is a new scientific field in the crossroad of photonics and pharmacology, focusing on the fundamental and applied aspects of the use of optical signals analysis, spectroscopy to improve the effectiveness of pharmacotherapy. Pharmacophotonics can solve some problems, particularly assessing the concentration of drugs and their metabolites in body fluids and tissue, identification of physical biomarkers to predict response to pharmacotherapy, development of new approaches for personalized pharmacotherapy. One of the main tools we used in field of pharmacophotonics was Raman spectroscopy. The method of Raman light scattering can provide extensive information on the chemical composition and structure of biological molecules, drugs, and their metabolites. In our study, a laser with wavelengths of 532 nanometers was used. Raman spectroscopy has a number of advantages over omics technologies. In particular, complex sample preparation is not required, and there is no destruction in the biological sample. Raman spectroscopy provides information that can only be obtained by performing several studies using omics technology. Using a single Raman spectrum of a biological sample, it's possible to obtain information on the structure and or composition of proteins, nucleic acid, lipids, and metabolites of low molecular weight substances. In next part of my presentation, I would like to present you some initial results of our research team, our research new approach on the use of Raman spectroscopy to personalize the use of antiplatelet therapy. We formulated two working hypotheses. First one, there are differences in the platelets Raman spectra in patients with cardiovascular disease and healthy individuals. The second one, Raman spectra of platelets can be used as a biomarker to predict the effectiveness of antiplatelet therapy. The main subject of our study was platelet-rich plasma, PRP. The methods of isolation PRP is well described in scientific literature. PRP was applied to quartz glass and studied on laboratory Raman spectrometer. Raman spectra were obtained on Centaur U Raman spectrometer, manufactured by Nanoscan Technology Russia, using DPSS coupled Samba excitation laser with a wavelength of 532 nanometers. On the slide, you can see our first platelet Raman spectrum. After examining our first platelet Raman spectra, we concluded that such spectra are insufficiently informative and not suitable for subsequent biomarkers identification. The slide shows that spectrum contain almost none of the peaks typically found in typical Raman spectra. This situation has forced us to use a more advanced methodology, and that methodology was a surface-enhanced Raman spectroscopy, SERC, SERS. SERS amplifies Raman scattering by molecules absorbed on raw metal surfaces or by nanostructures. To improve the sensitivity of Raman spectroscopy using the SERS effect, our chemists developed a special anodized titanium substrate with gold nanoparticles. The slide shows the developed substrate under an electron microscope. Thus, after development nanostructured titanium surface, we modified the process of recording Raman spectra. We began to deposit platelets not on quartz glass, but on developed titanium substrate with nanostructured gold particles. This approach allows us to obtain a high quality Raman spectrum of platelets that could be analyzed. Dear colleagues, let me not go into details of the development of nanostructured titanium surfaces, nor on the technical details of recording Raman spectra. You can find this information in our publications, the main ones I present on this slide. For your convenience, the DOI numbers of the articles are given in the QR codes. The graph on the left shows the Raman spectra of healthy individuals and patients with cardiovascular disease. You can see that Raman spectra show different peak values at some frequency shifts between healthy individuals and patients with cardiovascular disease. We also found differences in Raman spectra of healthy subjects and patients treated with antithrombotics. However, when we started to analyze platelet Raman spectra in more details and trying to identify specific biomarkers, the challenge for us was processing large volume of data set. On the slide, you can see a graphical surface representing a set of data obtained from just one platelet sample. To solve the problem of identification for biomarkers in large data set, we have used the help of machine learning experts and the application of specific mathematical algorithms. Using machine learning approach, we were able to identify the 21 frequency shifts on the Raman spectra that are most informative for further investigation. The values of the spectral peaks measured at these frequency shifts are candidates for biomarkers development for diagnostic tests and personalization of pharmacotherapy. You can see this frequency shifts on the slide to the right. Our next step was to try to understand which specific pharmacodynamic targets of antiplatelet drugs the Raman spectra might correlate with. For this purpose, we studied platelet activity using different cartridges of Innovent's PFA 200 aggregometer at the same time as obtained platelet Raman spectra. Significant correlation were found only for the test detecting platelet dysfunction associated with P2Y12 receptor. Thus, we can conclude that Raman spectroscopy can be used to diagnose increasing platelet activity and assess the pharmacodynamic action of antiplatelet drugs in patients with cardiovascular disease. It's likely that the change in Raman spectra of platelets are related to surface receptors, especially P2Y12 receptor, but not to COX-1 activity. Another potential application of Raman spectroscopy is to study the concentration of methotrexate and its metabolites in order to optimize dose adjustment. We are only at the beginning of our research in this area. Our research team has now developed a planar SERS sensor that can detect methotrexates in biological samples. This sensor has been used to detect methotrexate specific peaks in Raman spectra. We are currently starting to form cohort of patients with rheumatic diseases to study this method clinically. I hope that we'll soon be able to enroll a sufficient number of patients and present the result of these studies. In conclusion, I would like to make it clear that we are at the beginning of the innovation process, at the stage of testing the innovation hypothesis. But we are very hopeful that we will soon move on the laboratory prototype phase. Our ultimate goal is to develop a portable device for testing at the point of care. In conclusion, pharmacophotonics is one of the promising tools for the development of personalized pharmacotherapy. The use of plasmon-enhanced spectroscopy, Raman spectroscopy, SERS, allows us to get a number of advantages over traditional omics technology. The most effective development of the pharmacophotonics direction is possible only as a junction of different scientific disciplines with participation of scientists of several profiles, pharmacologists, optical physicians, chemists, IT, and other scientists. Thank you for your time and attention. On the slide, you can find my email address. I will be happy to answer your question. Thank you.
Thank you, Prof. Rafalski. Okay, Prof. Ming. Right, so Prof. Rafalski, we will chat with you later. There will be interactive sessions involving all panelists. So the next panels is from Bath University, UK. Associate Prof. Dr. Nicoletta Fotaki, right? He's a scientist from the Faculty of Pharmacy. So she'll be sharing with us the biopharmaceutics modeling in pharmaceutical innovations development. So Prof. Fotaki.
Good afternoon. Can you hear me?
Yes, we can hear you.
Fantastic.
I can't see you. Yeah.
No, I'll do everything. Don't worry.
All right.
Okay, now you can see me too, and I'll share my screen, I guess.
Okay. So the share button is at the bottom, green color.
Yeah. Give me 1 second. I'm just trying to find the correct one. Can you see my screen now?
Yes, we can see your screen and we can also hear you clearly.
Fantastic. Okay, just in terms for the time, I would like to thank you first of all for the invitation. I know that it's afternoon for you there, it's early in the morning in UK. And I would like to give you some perspectives on biopharmaceutics modeling in pharmaceutical innovation development. So just I want to give a bit of a basic framework of the physiologically based pharmacokinetic modeling. Probably most of you are aware of these. These are mathematical models that integrate anatomical and physiological parameters of animals or humans, physicochemical properties of drug substances, formulation properties of drug products, and they are mechanistic quantitative platforms for the prediction of the in vivo performance and for formulation development. Usually, for developing these type of models and validate them is a whole process, but my main point here is that We can use them for several reasons, and we can use them to predict the bioavailability in several populations, healthy or special populations like pediatrics or geriatrics or disease states. And it's really a very valuable tool also for formulation development, to define the critical variables and to develop and select the appropriate formulation. And there it comes the physiologically based biopharmaceutics modeling, what I'm going to talk to you a bit about and give you a couple of case studies. So the physiologically based biopharmaceutics modeling is something that has been defined recently even from FDA. And in this case, we really use the PBBK modeling in biopharmaceutics. So the point there is like how, the importance of the appropriate biopharmaceutics tools for modeling the in vivo behavior of the oral products, and relates with the aspects of several processes like solubility, dissolution, permeability, and so on, and to understand how the gastrointestinal physiology influences all these parameters. Now, the question is always, the input of data in these models. I mean, modeling is easy, in general, you can just put values, but the point is like you need to know what value you have to add. So you have to have really good in vitro data and appropriate in vitro data, and to be in vivo predictive. And this would refer to several aspects, as I say, in terms of the drug substance or of the formulation, but also, aspects regarding degradation, metabolism, transporter studies, and so on. And then it depends on where you're going to do the formulation that you should, sorry, I'm sorry, just to close the window. Okay. So in this case, it depends which type of media you are going to use to do your studies, which type of apparatuses you are going to use your in vitro studies. And this is a whole process that we do a lot of research, because you need to have biopredictive in vitro models. I'm not going to go in detail now because in the interest of time, it's not this point here, but the point is really always that your in vitro test should be biopredictive. Now, we have several challenges because, as I said, it depends on how you are going to set your in vitro test, what kind of conditions you are going to use. We have several in the literature, and of course, several are really case by case. And then it has to do a lot, you have specific data even for specific drugs, as I said, for example, the transporter studies, you need to have this information for your modeling. And even like when you want to talk about it, to find out which is the best formulation for a special population, like the pediatrics, or when you have a disease state, how you are going to set your model, because you have to take into account all the physiological parameters in this case. So I'll just give you a couple of case studies that we have worked in my lab, just to show how the physiologically based biopharmaceutics modeling is working and what we can see. So the first case will be for the prediction of performance of liposomal formulations in healthy and critically ill patients. This was a series of studies that we have done. I'll show you just some major results from this one. So for the liposomes, it's even more difficult the case than an oral formulation. All the aspects, all these biopharmaceutics modeling have been developed quite a lot for the oral development, but we don't really have all these biopredictive tests yet for liposomal formulation. So in that case, we developed and we studied different in vitro tests in terms of like sample and separate methods or continuous flow, and we took into account really the conditions of the critical ill patients and the healthy conditions. So we tried to simulate this in terms of the appropriate environment there, the media that the liposomes will be exposed. And we developed what we call clinical relevant media. And we took into account, of course, as you need really to take into account in this case, the protein levels. So we had all these physiological relevant conditions in the in vitro testing. So we did some release studies of the amphotericin B liposomes in these conditions that I mentioned, with different setups that I mentioned before. So we have the with low and different hydrodynamics. So we had with low agitation or high agitation in the sample separate method, or the low velocity and high velocity in the flow through. In that case, as you can see, I will not go, as I say, because we don't really have so much time in detail to explain each graph, but the point here is that you can easily see that the type of the buffers or what you use as a medium has an impact on the release from the amphotericin from the liposome, but also you have an impact of the presence of the protein. So you can see that the dotted lines are the media without protein. So you can see always that there is a difference when you don't have a protein or when you have protein in your media. Now, then what we did this in vitro tests, and then we really developed a PBPK modeling of the liposomal and the released amphotericin B, because this is another challenge that you have with this type of formulations. It's not like the oral that you will just have the released drug, because you will have also the liposomes going around in the bloodstream. So based on the model, that we had quite good predictions for the liposomals and the release, because we could measure also this in the in vitro setup. So we used the in vitro setup that I showed to you before, the release studies, and we entered this in the model that we built. There also you can see that in this case, we have the opportunity to understand a bit the impact of different factors on this type of the release. So we can see clearly, for example, that the protein levels are really essential. And then in this case, the aspects for us is like how you can use the PBPK modeling to evaluate your in vitro release. So when you want to set specifications, when you want to develop your in vitro test, by having the modeling, you can see by adding the different in vitro profiles, you can have this type of in vitro in vivo correlations, but mainly we can define really what would be the appropriate test that you have to do. So in that case, you see that again, for these liposomal formulations, you always need to have the albumin, the protein level present. And then just I'll go very quickly from this aspect that we can do also the PBPK PD modeling for the patient, so to see the pharmacodynamic effect. And in these cases, we can develop this type of models for the healthy and the critical ill patients. And with the modeling, we can see the effect of the different levels of albumin on the on the time killing rate coefficient. So again, we can have this pharmacodynamic effects simulated, and this is another aspect of the PBPK modeling that you can link it to the pharmacodynamic one. And then I'll just go very quickly from the second case study that it's really for the pediatric formulation, how you can do and how you can predict formulation performance in children. So in that case, we had worked with a model compound, Montelukast sodium, and have a look and pay attention on the high lipophilicity of this compound. And with that one, you know, we talk about pediatrics. We used small scale dissolution studies with a microdis and different conditions, again, or having a single medium or two media to have sequential media change from stomach to the intestine. And we get different results, of course, in this case, from these chewable tablets that we give to children. So we can see that, you know, or if you have gastric exposure or only intestinal exposure, or if you have, like, as you can see in the third graph on the left, on the right, you can see this sequential change. So how you can see how is the performance in children and how is the performance in adults. So we do different tests, adults and children simulations. Then we develop a model, in PBPK model, or PBBA model, and the way that we do that is from going from adults to the children models. We enter all the important, let's say, disposition parameters and everything that has to do with the drug. And then also we play there a lot again. What is the input of these release studies that you have? How you can, how can they help you to have a validated model? And for these type of models, we use different values really to validate them, as I said. So yeah, in that case, you know, we have the average fault error or the absolute average fault errors that we calculate. So just to see a bit of like the process quickly is that we go from the adult PBPK model, we do the intravenous model for the adults, then the oral solution for the adults, and then we develop the adult model, and based on these different in vitro studies that I showed to you. And then we go to develop the model for the children. It's not an extrapolation, keep this in mind, you know, because in the past that we didn't have a lot of information for children, we didn't really use, and it was very common just to do an extrapolation. Now we built the models and we know how is the performance of the formulation based on the population and not extrapolated just from adults. We just build the adult models to get confidence on our models. And then, you know, we use these platforms to see what is happening in pediatrics. So we can do this with the infusion and having the intravenous data, and then also the 2 tablet data. And you can see always that, you know, as you can see that we can get very good predictions with the in vitro, the biopredictive test that we have. Then again, another thing that you can do is that several times with this type of modeling, you can really do this kind of sensitivity analysis that we say. And the main point here is like when you do formulation development, you can really set your specifications. It can help you to define your target profile. So when you try to develop the formulations based on the modeling, you can define your target profile. And in that case, you can really then do appropriate formulation development. So I do hope that I'm on time. As I said, I'm just always very cautious about that. I do hope that I gave you a bit of a feeling or what you can do with this biopharmaceutics modeling, that we can really have good in vitro in vivo correlations. And it's really important, the input of data. You know, I mean, if you just put a test that has no physiological meaning, probably, you know, it will not really have any, you know, good prediction. So the type of how you design your in vitro test is essential. And then you can really support drug development in pediatrics, but also, you know, I have to say we have case studies that we did that for disease states and so on. So we have quite a lot of case studies that we use this. Nowadays, all this type of modeling, you know, is acceptable also from regulatory agencies like the FDA. So in drug approval is something already that you can check and share how you do your formulation development based on this type of approach. So at this stage, I wanted really also to acknowledge, of course, the people who worked with me on these 2 projects that I shared with you, that these are published. So we have done a lot of work on pediatric biopharmaceutics for several years now. So, and then also for the liposomal and parenteral work. And of course, the funding was from Horizon 2020 for the pediatric project, and also from CONACYT for the liposomal one. Thank you for your attention. You can contact me if you have any questions. I think that, you know, you can easily find my email, or I'm happy to share this with you. Thank you.
Thank you, Prof. Fataki. So Prof. Fataki and Prof. Weiwei and also Prof. Rafalski, so we'll be having a short break. So I hope you can stay with us, because there will be interactive sessions at about 5:20 p.m. Malaysia time, right? So we'll be having a short break until 3:55. Now it's 3:43 p.m. Thanks. Thank you very much. Should we start? Yeah, Prof. Meng is on the line.
All right. Professor Wang, shall we move on?
Yes, yes, Prof. Meng.
Okay, all right. Next speaker, Professor Yi Jun Zhu. Let me briefly introduce Professor Zhu. Now he is Associate Vice President of Macau University of Science and Technology, Dean of School of Pharmacy, Chair Professor, and licensed physician of University Hospital. He is a Vice Chairman of the Chinese Medical Association of Macau, China Association of Chinese Medicine of Macau, and another titles. Professor Zhu has served as Dean of School of Pharmacy at Fudan University, a very famous university in China, for nearly 10 years. And he is rewarded as a Changjiang Distinguished Professor of Ministry of Education. His research interests include the basic and clinical research on cardiovascular and inflammatory and immune disease, and also the aging. Professor Zhu has published more than 313 scientific papers, which were cited for more than 15,000. His H index is 67. Also, many of his patent was converted into the dollars. All right. Because his outstanding achievements, Professor Zhu was ranked as the world top 100,000 scientists and the world top 2% scientists in by Stanford University. Let's welcome Professor Zhu.
Everyone. So this is my great joy to join you for this forum. And also many thanks for the invitation from my Hefei friends, the Professor Wei Wei, and also Professor Sun. So my topic today is focused on the drug discovery of novel compounds from bench to bedside. So which means this is from the idea to the clinical trial and surely finally to the market. So I'm from Macau, so I'm mainly working in the university, and also I'm a physician working in the university hospital. And surely I have one research lab in Fudan. So therefore, I'm the poor guy, one job with 3 bosses. Okay, so this is a little share with you about the drug discovery from natural products. So as you all know, so the traditional TCM is very famous, but for drug discovery, so TCM, I don't think this is very useful for the single compound discovery. For the single compound, we mainly use the SCM, Scientific Chinese Medicine. So this is from my idea, but we are sharing with you the story of our SCM. So this is our single compound, as you can see here from the left side. This is the herbal limonene, and herbal limonene is in Chinese called 益母草. But we extract and finally chemically synthesize the single compound limonene called SCM-198. So this is the animal model in the rabbit. So as you can see here, this is the normal aorta of the rabbit. So this is the 6 months with high cholesterol diet in the rabbit. As you can see, after 6 months, so the plaque formed, but at the same time, we treat the animal with our low dose, middle dose, and high dose of the limonene. And then you can see here, especially with the middle dose and high dose, the size of the plaque reduced significantly. And but at the same time, when we use the statin, you all know this the very famous the clinical usually for lowering the cholesterol and the LDL. But statin, they don't have the significant effect on reducing the size of the plaque, same as the very famous drug aspirin. So therefore, as we published this paper, so the journal made a very big editorial comment, say that this from the nature, we have such a wonderful compound affecting the atherosclerosis. So we also found this effect on the stroke, as you can see here. The stroke, infarct volume reduced dramatically. So as you can see here, this is very significant. And as the Chinese have a single compound, this is the first time to publish in stroke at that time. So this also, we tried also to see whether this has any effect on the cardiac fibrosis. As you can see from this echo data, so the cardiac function improved dramatically, same as from the HE staining, as well as the in situ hybridization, and also the gene expression and protein expression. As you can see, the cardiac fibrosis reduced. However, really, if we may find some drug on the effect of the cardiac fibrosis, this is still a long way to go because the clinical significance is very difficult to reach. Also, we tried to see whether our compound can reduce the cerebral edema. You know, regardless this the ischemic stroke or the hemorrhagic stroke, the cerebral edema is very significant issue. So, as you can see here, we showed only that the cardiac, cerebral edema can reduce significantly. So regardless, this is in the hemorrhagic stroke or in the ischemic stroke. Most convincing data are from the monkeys. So as we can see here, this is the monkey data. The purple color, this is the statin. This is our leonolin, and the blue color is the statin. As you can see, for lowering the LDL in monkeys, so our leonolin is even better than the statin. So which indicates the very potential the clinical use in the future. So also most promising data as we got recently, this is for stabilizing the plaque. So you all know if the job of the plaque is very critical for forming the blockage of the vessel. So if something would be stabilized the plaque, this would be very significant. So we surprisingly to find that our SM118, they have this great effect, which could be very potential in the future. So surely before we move to the druggable candidate, so we have all the data to confirm the structure and also the crystal forms. There are in total 6 different crystal forms from the leonolin, and finally we select only one most significant one and also most effective one to be the drug candidate. So also the crystal form A and also its pharmacological effects. So we did a lot of study, so I won't list one by one, but we just moved to the clinical trial from the most effective the therapeutic use. For instance, this is for lowering the cholesterol, for lowering the triglycerides, and especially for the reduction of the oxidized LDL. Indeed, oxidized LDL is most important, much important than the LDL. So this will be seen the effect in the future from the clinical trial. So also we got several recognition from the big pharma, especially we signed the MOU with AstraZeneca. So most likely we will work with them together for the global clinical trial. Also in the Sigma catalog, they put also the SCN198 as the potential compound as drug in the Sigma catalog. This is the first Chinese herb single compound listed in the Sigma catalog. So also we are working still on the new targets. So although we published before, NOX4 could be the target for our limonene. However, we are still finding that some new target, for instance, the caveolin-1 and the vigilin. So they are potentially working for the molecular basis of the limonene. So this could be very potential. So we are working on it. And also, as you can see, the load of our SN1H limonene, this actually really a very long way. So we started in 1999 as I was PI in the National University of Singapore, and we started this chemical synthesis of the limonene in 2006 as I start to work in Fudan, and then we completed all the druggable process of including the larger scale production and the pharmacological and the new formulation and the PKPD and tox study and so on. So these all need time and money. So finally we got the clinical trial license, and we completed also the phase 1 study, and we are now in phase 2, and hopefully so we may get the final approval from the authorities, especially also from the FDA in the future. So this is the data from our phase 1 clinical trial. So we did 106 volunteers to take our drugs. So from the single dose, multiple dose, and also to see the effect, the interaction with food, with other drugs, and so on. So also with very nice data from the PKPD. So as you can see, we also surprisingly found that there's a trend for the novel, the mechanism for lowering the cholesterol, for lowering the triglyceride through the signaling pathway of the cysteine and methionine metabolism. So this is the first time to report this. So I think this is also very interesting. So we are still working on the phase 2 sample now. So try to confirm this fact. So and this again, not only the methionine, also the homocysteine. So they work together for lowering the oxidized LDL and also the other effect. So, and you can see here, this the hydrogen sulfide and also the new compound. So as we wish to report to you. So this is the second compound that we are moving to clinical trial. So firstly, as you can see here, the single compound from the garlic, this is also more than 30 different single compounds. But which one is most effective? So we tried to isolate all these compounds, and finally we focused on the SAC. SAC is the single compound that can release the hydrogen sulfide. As you can see, this molecule is the hydrogen sulfide, and we published a small article in the AJP, and but surprisingly, they made a very big editorial focus and described this finding is so great and made the garlic to smell scientifically first through the mechanism of the hydrogen sulfide. So this is really a very big comments. So so we are still working on it. You all know the hydrogen sulfide, and this is the third gasoline transmitter But the first one, very famous, is the nitric oxide. Nitric oxide, they got the recognition from the Nobel Prize, and they got also the recognition from the pharma industry. We all know the famous drug Viagra. Viagra is actually indeed from the effect of the nitric oxide. So, but potentially hydrogen sulfide may be more potential than the nitric oxide in the future. So, if you read this paper, so you may understand better for the hydrogen sulfide. So the hydrogen sulfide, we published the whole story. So, and this hopefully may give you a new pathway to understand the novel compounds and also the new signaling pathways and so on. So, and this is the single compound, as you can see here, the gasoline transmitter. Actually, this is released very slowly, but this is through our new formulation. And the new formulation, as you can see here, this is also the microsphere. Microsphere is very difficult to form it. So this is our microsphere formulation, and also we complete all the necessary documents for filing the FDA or the Chinese CDE, the clinical trial. So we are doing now. So this therefore the first in class compound from garlic. So they was A02. So SPRC. This is modified structure from the SAC. So we focused on our indication for the autoimmune disease, especially for the rheumatoid arthritis. So, but at the same time, so we are also tried to have the druggable candidate from other candidates. For instance, the lycophyrin analog. Lycophyrin analog is actually the gluten. Gluten, this family, and we found that this is also very great potential on the diabetes caused vascular injury. So, and this is also very potential. We are working on it. And another analog called quercetin. Quercetin is also very interesting, and we have the quercetin new molecular mechanism on reduction of the liver metabolism for fat for the lipid. So this is also very interesting, and this they provided also the effect on the vascular protection. So this is we also recently published it. So therefore, if we focus on our chronic disease, regardless which disease, we can say immune response and inflammation are key factors. So this is the model we found in our vascular injury. So, and the HDAC find that they played a very big role in the vascular inflammation. So as we published this paper, the journal made a very big editorial comments again. So they say that this is the killer for the vascular inflammation. This is really a very big admire on us. So therefore we are trying to move to the next stage. You know, the vascular inflammation is the first stage, and the following stage is the vascular injury. What happened by the vascular injury? So we found that the GMJD3 are the key factors that caused the vascular injury. As we published this paper, so the journal made again an editorial and say that the vascular injury and the GMJD3, the M+ nucleosis, which means we disclose the M+ nucleosis and to confirm the first time effect from the GMJD3 on the vascular injury. So therefore, as you can see from the vascular inflammation and the vascular injury, and this is the first two steps to lead the last stage of the vascular senescence. The vascular senescence is the blockage of the vessel. So this is, but what happened in the vascular senescence? We found that the SMIC3 is the key factors involved in the vascular senescence. So this we published in the Aging Cell, but still no much know about the SMIS-3's role in the vascular senescence, including its proliferation, its migration, and its new interval. So therefore, we published the exactly molecular basis of the SMIS-3. Also, the SMIS-3 is actually working on the PAP16 together. So they are the SMIS-3 PAP16 axis. So these to lead the vascular senescence. Therefore, we are working on the different inhibitors to block the process of the vascular senescence. So this give you the example. So this is the drug development load for identifying such blockers for those key proteins. As you can see here, this the SMIS-3, the structure, but very important is the SMIS-3 structure. We should use the pathological structure. So and this structure, so we used our Nature product data bank to screen our 50,000 compounds. So we screened them and finally confirmed from all those synthesized or chemically modified structure and confirmed one as the very potential the drug candidate. So we are also moving to the IND now. So what happened if in the rheumatoid arthritis? In the rheumatoid arthritis, this also happened the vascular senescence. So because of the vessel, the blockage, and also the damage on the small joint and so on. So whether this also the SMIS-3 played a role, so we found that the SMIS-2 is important, but not the SMIS-3. Therefore, we published in the Clinical Translational Medicine. So the SMIS-2 actually we confirmed also from the eye patient and also from the synovial tissues and so on. So this is also surely we confirmed in the animal model. So therefore, the SMIS-2, so whether knockout or wild type to confirm which one is better. So we tried to understand how to balance it. So therefore, to balance the SMIS-2 is a big question mark on the rheumatoid arthritis. But in the rheumatoid arthritis, the same is the vascular injury. The vascular injury in the rheumatoid arthritis, this is also the damage of the tissue, but this played also from the GMJD3, and this we also published in the Cellular Molecular Immunology. And this is the mechanism that the hydrogen sulfide donor actually to stop the phosphorylation of the MARC, and also they block the phosphorylation of the SP1, and finally they have the effect on the blocking the GMJD3, and then for the rheumatoid arthritis. So recently also we found that this very interesting story is from the general vascular aging. So which protein would be responsible? We found that the KIT family played a very important role. So therefore we already submitted a paper on the discovery of the importance of the KIT family in the general vascular senescence. And also we used the CRISPR-9 knock down the KIT family. And also we also to see how do we activate the KIT family. So knock in the KIT family and really confirmed our hypothesis that the KIT family played a very important role in the vascular senescence. If the level of the KIT family increased, then the vascular senescence might be reduced. Also, so we tried to understand another question is, so because the patient always ask why the rheumatoid arthritis, they have the wandering pain. So to answer this question, we start to another study, try to find the novel protein responsible for the nerve for the pain of the rheumatoid arthritis, we found that the nerve 2, actually the nerve 2 is the neuronavigator 2, is responsible for the rheumatoid arthritis, but not for the osteoarthritis and or the healthy volunteer. So therefore, we found that this is the high level expression in the rheumatoid arthritis, and not only confirmed by the patient, but also confirmed in the animal model. So this is the high level expression. If we block the nerve 2, and then the wandering pain will be reduced. And we are also doing to discover some novel proteins relate to the nerve 2, and the papers are on the submission. So this is the summary for the story of the nerve 2 as we invite by the cellular molecular immunology. So because this is very interesting to see how the nerve 2 works. Nerve 2 actually works on the GSK3 beta and also further on the beta catenin, and then finally work on the MMP family and the cyclin D1 and the Cmax, and so on. So this is for the final effect on the cell fate proliferation and invasion. So recently, we also published a very exciting paper on how the nerve 2 works. The nerve 2 actually works with the STAN3 together. So these nerve 2 and the STAN3 axis play the common role. So therefore, this is very interesting, and this is how the nerve 2 STAN3, the axis, they work for the migration and the invasion in IA patients. So this is the continuation story is for coming very soon. So we have also listened to very exciting story. So for our above these works, so we filed more than 80 different the patents, and we also received a lot of the patents grant and so on. So this not only in China but also in the EU and other in the United States or in Japan. This our group, so we mainly working on the inflammation and also immune response. This is my macaque group. So we was also in my group, but not in this group photo. This our recent photo, and also I have another group in Fudan. This my Fudan group, and so on. So finally, thanks again for the invitation from this wonderful forum, and hopefully next time we can see you all together offline. Thank you.
Okay, thank you, Prof. Zhu. Prof. Ming. Yeah.
Yes, I'm here.
Yeah, I think the subsequent two speakers, perhaps you can introduce them. Yeah.
Okay, all right. Yeah, next speaker, Professor Hai Yongchen. Let me briefly introduce Professor Chen. He is a PhD student, assistant professor, and a registered Chinese medicine practitioner in the School of Chinese Medicine, Li Ka-shing Faculty of Medicine, the University of Hong Kong. He graduated from University of Hong Kong and get his PhD degree in 2012. He has diverse research interests. His current studies focus on the molecular mechanisms of kidney disease, as well as evaluation of the effectiveness of Chinese medicine for common diseases with evidence-based approaches. He has actively published over 80 peer-reviewed papers. Let's welcome Professor Chen.
Okay, thank you. Let me share my PowerPoint. Okay, so thank you for your invitation and kind introduction. So today I'm going to share some studies from my group, and we will talk about some molecular mechanism and the Chinese medicine studies on the diabetic kidney disease. So the patients with diabetes account for over 10% of population, worldwide population. So 30 to 40% of patients will develop into the diabetic kidney disease, DKD. So DKD is the leading cause of end stage of renal disease, and 30% of ESRD patients are due to the DKD. So in our previous studies, we demonstrated that TGF-beta mediated fibrosis and NF-kappa B driven inflammation play a very important role in the pathogenesis of the DKD. So we hypothesize that the targeting on these pathways may represent novel therapies for the DKD. So in our pilot study, we found that the SMED7 is significantly decreased in the diabetic kidney. So we hypothesized that the loss of SMED7 in diabetic kidney may promote the pathogenesis of DKD. So to test this hypothesis, we use the SMED7 knockout mice and treated with the STZ to induce the type 1 diabetic mice. So as this figure shows that in the wild type mice, the disease model has a significant decrease in the SMED7. And also we showed that the loss of the SMED7 significantly enhance the microalbuminuria. That means the renal function, decline of the renal function. And the loss of the SMED7 also enhanced the TGF-beta SMED signaling, as demonstrated by the Western blot and the real-time PCR. So, and also enhance the fibrosis, as demonstrated the immunohistochemistry. Here, we can see the collagen 1 is significantly increased in the diabetic SMED7 knockout mice. Similarly, the loss of SMED7 also enhanced the NF-kappa B P65 signaling pathway, as demonstrated by the Western blot, and also enhance the inflammation, as shown here, TNF-alpha. So we found that the loss of SMED7 in the diabetic kidney aggregated by targeting the TGF-beta SMED signaling and the NF-kappa B signaling. So if we store the SMED7 in the diabetic kidney, can we restore the function? So we construct the SMED7 overexpression plasmid. Then we deliver this SMED7 genes into the kidneys, a diabetic kidney, by the ultrasound microbubble mediated the technique. So as shown here, these figures, the gene therapy, SMED7 expression can significantly reduce the microalbuminuria in the diabetic kidney. And also we found that the SMED7 gene therapy can significantly inhibit the inflammatory cytokines like the TNI1 beta, and also can suppress the infiltration of macrophage. As shown here, in the diabetic kidney, you can see many macrophage infiltrated to the glomeruli, while in the SMED7 treatment, the infiltrating macrophage are significantly reduced. Also, we found that the SMAD7 gene therapy can also inhibit the activation of the SMAD3 phosphorylation and the fibrosis, as demonstrated by the immunohistochemistry. So, in the summary, we found that the loss of SMAD7 enhanced the TGF-beta SMAD7 mediated fibrosis and also enhanced the NF-kappa B signaling pathway by inhibition of the phosphorylation of I-kappa B alpha. And recently, we also find the loss of SMAD7 in diabetic kidneys because of the upregulation of Arcadia. The Arcadia is a ubiquitinase protein. It can degrade the SMAD7 in diabetic condition. So we found that if we use the latent TGF-beta to suppress the Arcadia and also can restore the SMAD7 in the diabetic kidney and also can suppress this fibrosis pathway and also the inflammation pathway. So as shown here, we use the latent TGF-beta transgenic mice, and in the wild-type mice, you can see the diabetic mice kidney had a significant different decrease in the SMAD7, while the latent transgenic mice overexpression of the latent TGF-beta can restore the degradation of the SMAD7. And as shown this slide, as shown here, the Arcadia is negatively correlate with the SMAD7. You can see in the wild-type mice, in the diabetic kidney. So the Arcadia is significantly increased. That means the Arcadia can increase the Arcadia can decrease the SMAD7 by using quinine. So in the in vitro study also shows the similar findings. So here we treat the cells with the normal glucose level and the high glucose and the mannitol. Mannitol is the osmolarity control. So as shown here, the high glucose can significantly activate the TGF-beta SMAD signaling and the NF-kappa B signaling and enhance the fibrosis and inflammation. And also high glucose can reduce the SMAD7 and increase the cardiac expression. So next we knock down the Arcadia to see if Arcadia can regulate the SMAD7. So as this figure shows that when we knock down the Arcadia, the SMAD7 increased. SMAD7 increased and also abolish the latent TGF-beta on the glucose-induced the fibrosis and inflammation. And the overexpression of Arcadia and also can prevent the loss of the SMAD7. And also can promote the effect of the latent TGF-beta protein on the high glucose-induced fibrosis and inflammation, which can inhibit the Arcadia-mediated SMAD7 degradation. So let's move to the Chinese medicine. So Chinese medicine has been widely used to treat the diabetic kidney disease for a long time. So our recent review indicates that the Chinese medicines can also prevent the renal fibrosis by suppressing the TGF-beta SMAD signaling pathway. Like here, we can see some herbs called the duzhong and some pure compounds from the Chinese medicine, berberine, and also Chinese medicine formula like Caihu, Yisheng granule, and Tangsheng formula, which can suppress the activation of the TGF beta and the SMAD signaling, and to reduce the renal fibrosis in the diabetic kidney. And our review also shows that the Chinese medicines can prevent against inflammation by suppressing NF-kappa B P65 activation and ROS activation pathways. Like this figure shows that the berberine and phenylephrine, like as Professor Wei mentioned, phenylephrine, and also like the amiodarone, this pill compounds also can suppress the inflammation by targeting on the NF-kappa B signaling pathways. And also some Chinese herbs and also Chinese medicine formulations like the Tangsheng formula, Cai Huang Yisheng granule, and the Jiangtang decoction can also suppress the activation of NF-kappa B and the ROS signaling pathways. So we focus on our study focused on another Chinese medicine formulas called the Buyang Huanwu decoction. So Buyang Huanwu decoction is a classical Chinese medicine formula that has been empirically used for diabetic kidney disease for over 15 years. So this decoction, BHT decoction, consists of 7 herbs, and the astroglycerides is the major component in this formula. It's accounted to 80% in the dry weight of all Chinese herbs in this formula. So, and in the Chinese medicine theory, BHD has a function to nourish qi and promote the blood circulation. However, the therapeutic effects and the mechanism is unknown. So we use the STZ to induce the diabetic mice and observe this function, observe the efficacy and the mechanisms of BHD on the DKD. So we use the low dose and high dose of the BHD to treat the mice for 12 weeks, and also use the IRB. That means irbesartan is a positive control. Irbesartan is the AT1 blocker that can reduce the blood pressure. So it's the ARB blocker. So as this figure shows that the BHD can significantly can reduce the microalbuminuria in the diabetic mice with a dose-dependent manner. However, BHD cannot reduce the blood glucose. And also we found that the BHD can reduce the renal fibrosis and also the inflammation markers in the STZ-induced diabetic kidney. As shown here, in the high dose of BHD can suppress the fibronectin collagen 1. This is the fibrosis marker in the kidney. And also can suppress the IL-1 beta and the TNF alpha. It's the inflammation markers, also in the dose-dependent end. And then next we examine the mechanism. We found that as the high dose of BHD has the best effect. So in the next the mechanism studies, we use the high dose of BHD to test the mechanism. So we found that in the diabetic kidney, BHT treatment can suppress the phosphorylation of the SMAD3 and also can suppress the activation of NF-kappa B. Importantly, we found that the high dose of the BHT can restore the SMAD7 in the diabetic kidney and can suppress the accardia. So in the in vitro studies, we also test the effect of BHT. So in the in vitro study, we use the SIH3 as a positive control. SIH3 is a SMAD3 inhibitor. So as shown by the Western blot, we also found in the high glucose treated cell, tubular epithelial cell, we found that the BHT can suppress the activation of phospho-SMAD3 and phosphoprotein 65. And consistent with the in vitro studies, the BHT can restore the SMAD7 in the high glucose treated cells and also suppress the accardia in the cells. So as I mentioned before, the astroglycan radix is a major compound in this formula. It's in the dry weight is it's accounted for over 80% of dry weight. So we screen the active compounds in these Chinese herbs, and we found that the caline-cousin 7 glucoside, this active compound, can protect against the high glucose induced the fibrosis and the inflammation. So as we showed here, the CG is the active compound, can also reduce the fibrosis levels of like the fibronectin and collagen 1, and also can reduce the inflammation markers like the I1 beta and TNF alpha, and also can reduce the phospho-SMAD3 activation. And also we determine the phosphorylation of the NF-kappa B pathway. So we also found that the CG treatment can reduce the high glucose induced phosphorylation of NF-kappa B P65, which was associated with suppressing the accardia and restoring the SMAD7 in the high glucose treated cells. So summary, so in our study, we show that the TGF-beta SMAD-mediated renal fibrosis and the NF-kappa B driven renal inflammation is the major pathogenesis in the diabetic kidney disease, which is associated with loss of SMAD7. And accardia mediated SMAD7 degradation contribute to the loss of SMAD7 in DKD. And the Buyang-Huanwu decoction, BHT can protect against the DKD by restoring the SMAD7 and suppressing accardia, and finally attenuates the TGF-beta SMAD-mediated fibrosis and the NF-kappa B driven inflammation. So here is my presentation. So thank you for your attention.
Thank you, Dr. Chen. Thanks for this talk. All right, we move to the next speaker. Mr.
Hello.
Hello.
My name is Zhang Tongtong.
Yeah. Is there any question?
The question session will be shortly. We still have 2 more speakers. So do bear with us, and I will see you in 40 minutes time.
Okay.
Yeah, thank you. Thank you for understanding.
Thank you. Let me briefly introduce Mr. King Lo Hong King. He's now work for the Whitehouse SDN BHT. Yeah, he's global medicine for primary patient care. Welcome, Mr. King.
Hi. Can you see me?
Yes.
Okay. Thank you. Good afternoon to everyone. Thank you for inviting me to share about a little bit that how we actually is a practice like personalized herbal pharmaceutical in the primary setting, especially in the pharmacy setting. Let me share about. I cannot share my slide. So
the share button is at the bottom. Can you see there's a green button? Yeah.
Share screen.
You click on the green button, share screen.
Share screen. Okay, I got it. Okay. Science. Hi, okay. Okay, can you see it?
All right, we can see the PowerPoint and we can hear you clearly.
Okay.
Yeah.
Okay. Sorry for the trouble. Okay. Thank you for inviting me as sharing some of the practice that is a personalized herbal pharmaceutical in the primary setting. Myself is a graduate pharmacist that is almost 20 years. Now from those days until now, from the practice from the Western medicines, we're talking about the drugs medicines, now more and more herbal pharmaceutical, especially from the TCM extracts, getting more and more potent and more, we call it as single active ingredients compared in those days. So, and for us as a pharmacist and in the Western medicine trains, we always have those days we always have a problem that is how we using herbal medicines actually to apply to our primary healthcare patients because we are not well trained at using of herbal medicines. Due to the technologies like herbal, we so-called genomics technologies, IoT, big data, so enable for us as much more easier nowadays that is using such of data informations to let us to use these extracts actually is more personalized. Let me share that is what we are doing now. Actually, we are using the biometrics data from those are like IoT smartwatches. Those are like Garmin's, like smart. We so-called as Huawei bands, Mi Band, or this thing. Like for example, heart rate variability, sleep quality, physical activities level, sleep quality. I mean, there is a heart rate variability. So from here, actually, we are combined to develop the algorithms to come out we so-called generally our patients' body's recovery stress score, which is in the 3 color, that in the green, yellow, and red. And why this is very important in primary setting? Because in primary setting, we are not really go deep into the clinical data presentations, and also that is we are not really fully assess the informations from those patients. Like in the hospital setting, normally the patient will go through the very sophisticated CT scan, laboratory tests, and even some of them is we so-called is those are radio imagings. But in the primary setting, like clinics, like we so-called is the pharmacies, we normally lack of such information. So in order to get we so-called that is a precise or personalized dosage for this potent herbal pharmaceutical, so we decide that using the more easy biometric information for IoT to convert it to green, yellow, red, more toward the body stress, while just now the we so-called it is a data, biometric data from the this kind information, this kind of IoT devices. So, and this is what we are in our platform that is you can see that is we divided all the stress score in the 100 different scoring, and also there is we also identify the medication, actually the herbal that we are using for our patients, what is the stress indicator, whether it's effective or not effective, whether we're high stressor or less stressor. And beside that, we also can evaluate that is a time to time, day by day, that is what is the impact of our patients. So the green color is the body actually is lower stress, and the red color is acute stress, and also there is a yellow color is a chronic stress. So from here, actually there is a let me share that is one of the use case that is we are make us that is more understanding how we apply personalized herbal pharmaceutical by using these IoT devices. This patient actually complained of fibromyalgia. So when seeing me, so the first thing we evaluate their lipid profile. This patient lipid profile, liver profile, HOMA-IR, and body fat compositions. And also that is we evaluate the patient's medical history to assess that is there any like medical history that is a patient currently on, and also that what are the medication the patient's on. And of course, that is also important, the patient lifestyle, social economy, and also that is a stress level. From here, we can identify the patients, we so-called there is a risk factor, and also there is the possibility of the patients, what are the contribution factors, and whether is what kind of the medication or herbal pharmaceutical actually, herbal medicines actually suitable for these patients. From all these kind of informations, so we decide to use the one herbal medicines we call the black seed extracts, which active ingredient is we call the thymoquinol. So from here, the patient actually will be coming up that is using this thymoquinol. Of course, that in our platform, you can see that is we monitor our patients by daily, and according to scoring actually, and also that it comment from the patients from the diet they are taking, physical activity, and also there is the symptom percent, the phenotype actually is the progress, especially for this patient, the pain. And from here, from the data, actually that is we call it as our pharmacist will put in what is the recommended dosage, and also that is what are the exercise and what are the interventions actually will be changed accordingly. If let's say the patient in the red color zone, actually we are increased our thymoquinol dosage in the highest dose. And if the patient in the yellow zone, actually we are moderate dosage. And in the green zone, actually we maintain the low dosage. So, and also we from here, we identify that is we so-called that is the thymoquinol, the black seed extracts, according their stressful feedback also, whether necessary the the cumin actually dosage is needed to increase, even though they are in the red zone. Because sometimes we want some stimulants for our patient actually to improve their immunity response. And from this patient, we can see that actually at the beginning, their pain score is quite high, from 6 to 7, 7 to 8, until today, the pain actually reduced 2 to 3. And from the solution, actually what we are doing that is like just now I'm sharing from our platform, actually we are daily monitor our patient respond to the herbal pharmaceutical, herbal products, especially in this case is the black cumin, the black seed oil. And also there is to matching this information with the patient lifestyle. And also there is at the same time to monitor the patient compliances, to formulate the daily personalized dosage, realign the interventions, and also there is a make sure our patient actually comply to the intervention approach and also the supplements, the herbal medicines that is prescribed to them. And this is also that is most important, will help the patient to cost saving. So in order to reduce the unnecessary side effect or unnecessary, that is a dosage toward to the patients. And of course, there is and this program actually is to help us as a pharmacist, which is we are not well trained in the herbal pharmaceutical, like those are TCM, but it's much more easier for us to understand that as how to apply the single ingredients and single potent ingredients herbal extract toward to the particular patients in order to avoid the unnecessary herbal drugs interactions, and also there is a lifestyle and herbal interactions. So, and also there is we also, the most important in summary actually is we are thinking that we are providing that because now the herbal pharmaceutical becomes so potent and effective. So the daily interventions analysis is very important in order to avoid those side effects and also those are unwanted interactions. So, and also most important, we collect user by daily to understand the patient actually daily changes in their body rather than using the invasive point of care intervention approach. Actually, we are using the so-called continuing care intervention approach. So to let us to understand deeply how this herbal actually work toward our patients. And of course, that is very personalized. And we adjust the dosage according to respond our patients rather than to using the standard dosage to work to the patients for every day. So to improve the efficacy and also the efficiency of the medications, herbal pharmaceutical. And this is my presentations. So if there is any questions that maybe can ask me in the later sections. So thank you.
Thank you, Mr. King. Yeah, it's a very nice talk. Open a new window for me. Yeah, thank you. Yeah. Okay, the last speaker, Dr. Amin Malik Saha Abdul Majid. Let me briefly introduce Dr. Amin. He has received his academic field specializing in pharmaceutical science for the past 18 years, while at the same time endeavoring in the industry area. To date, he has supervised nearly 100 postgraduate students with more than 300 research publications. His research work stems from his collaboration between Malaysia and Australia University in cancer-related areas. Most of his research work in the field of botanical drugs targeting angiogenesis, particularly for cancer application. And this result product has entered phase 3 clinical studies for breast cancer, colon cancers, and so on. This is supposed to be the first botanical drug for cancer therapeutics. Currently, he has Nature Therapeutics, which is a pharmaceutical company that produces and markets botanical medicine, and also the Aman Biodiscoveries SDN PhD. This is a drug discovery company that supports the research needs to Nature Therapeutics. Let's welcome Dr. Amin.
Thank you very much for the kind introduction. I will be sharing with you the research platform that we have been using for drug development, and it's called angiogenesis. Angiogenesis is a process of new blood vessel development, and this process plays a role in a huge variety of human diseases, including cancer, almost all types of cancer. You have Alzheimer's, you have obesity, you have rheumatoid arthritis, you have diabetic retinopathy, and so many different types of diseases. And targeting angiogenesis can have potential beneficial effect in terms of drug development. So here what I'm going to present today is what we are trying to propose is to use angiogenesis as your screening platform for drug development. And I would like to share some of our experiences and successes in angiogenesis development drug discovery. So if you look at the angiogenesis itself, it is pretty much driven by inflammation. With inflammatory mediators, angiogenesis can be activated. And if one look at what can trigger inflammation, well, a lot of things can trigger inflammation. But one of the major things that can trigger inflammation is free radicals. Free radicals in the environment of hypoxia, if you are in the tumor environment, can switch on angiogenesis because it helps to form the transcription factor called HIF-1 alpha. And this HIF-1 alpha is a transcription factor to stimulate VEGF. It's a vascular endothelial growth factor, which is the key cytokine to trigger angiogenesis by binding to the VEGFR2 receptor. And of course, angiogenesis can also occur without VEGF, such as some of the work that our colleagues presented. One of this is NF-kappa B. So as you can, if you look at it, inflammation, free radicals, angiogenesis, they go hand in hand. So if you reduce free radicals, you can potentially reduce inflammation and you can reduce angiogenesis. So using this as the guidance, the guiding principle, if you want to develop anti-angiogenic or angiogenic modulated products, when we are dealing with natural products, some of the key things that we should look for includes herbal natural products which has anti-inflammatory properties, antioxidant properties. So these two key features may potentially stimulate or inhibit angiogenesis. In this slide presented to you here is a section of a red erotic ring, which we use as a ex vivo assay. This red erotic ring will, in a three-dimensional form in the media, naturally, if you look at slide 1, you can see tiny, tiny blood vessels being formed. That is their angiogenesis happening. So there are certain products which can make more of these blood vessels being formed. So they are, we classify as pro-angiogenic. Using this red erotic ring as a screening platform for angiogenesis targeted products, we can identify what types of herbal extracts, what solvent, or even small molecules that can potentially inhibit this angiogenesis. And the good thing of this angiogenesis platform, after the evaluation of the activity on this red erotic ring, we look at cellular aspect like the endothelial cells. We're more interested in products that are not cytotoxic towards the endothelial cells. Mainly, we're looking at cytostatic. So when you start off with a non-toxic substance, the likelihood of toxicity is going to be reduced. So there are many angiogenesis assays out there using different in vitro and in vivo model. But we find that this red erotic ring assay, and in our circumstances, we have modified it slightly, we find it to be robust and consistent, and it reflects to the clinical studies. That means the assay tend to validate what we find in clinical trial. Another method that can be employed for this angiogenesis assay, we can use chicken embryo. So the chicken embryo is a cheap approach where we can use fertilized chicken egg, and you can see in this case here how angiogenesis is occurring. So when you apply a product onto this chicken egg embryo, we can see whether it is inhibiting these tiny, tiny blood vessels that's being formed. So this screening tool is quite affordable. I mean, it can be done in anywhere around the world pretty much. So if you look at in our study, we were spending a lot of work on, in the initial phase, we were using this chicken embryo, and then we move off to the red erotic ring assay just now. So once you have good outcome from this study, as I mentioned previously, the main thing is now we want to make sure that how it stops this angiogenesis or how it stimulates this angiogenesis. And key thing is the non-cytotoxic activity is very important to move forward. Here in this slide is showing how we implant Matrigel in rats or mice and put pro-angiogenic substances to stimulate this formation, a kind of a tumor type, artificial tumor. And in this case here, we fed the animals and see whether later on towards the end of the study, whether it can stop this angiogenesis. In this case here, you can see the control, you have blood vessels being formed, and B and C giving a higher dose of particular extract, and you can see angiogenesis is being inhibited. So the likelihood of this particular product being anti-angiogenic will be quite good. The other model that we employ is using spheroid. It's a hanging drop assay. In this case here, we grow tumors in vitro pretty much, upside down, using co-culture by mixing endothelial cells and, in this case, colon cancer tissues, and make them grow into a blob. We can also use this as a screening platform to further validate, and also as a platform to see whether the drug of interest is penetrating into the spheroid. And here you can see, as we increase the dose of this particular extract, the tumor blob starts to to break down, suggesting that it has potentially anti-angiogenic. So those three platform we use quite routinely, and we have screened hundreds of different extracts, chemical compounds for anti-angiogenic or pro-angiogenic. So the next stage, as we move along, we want to see how it stimulates or inhibits its angiogenesis. In this particular work, we look at the phosphorylation of the VEGFR receptor. You can see that as we increase the dose, the phosphorylation of the receptor is being reduced. And also at the same time, we look at the expression of VEGF, and we can see that how we can reduce the expression of VEGF compared to the control. So natural product has that properties, unlike some of the monoclonal antibody drugs that we have in the market. They tend to target either the receptor or the cytokine VEGF. So in this case here, the potential of improve in potency is probably better and less likelihood of the development of drug resistance. So once we have established in the in vivo environment for angiogenesis inhibition, we can attempt to look at the tumor, the in vivo tumor environment. Of course, in this case, this is going to be potentially validated in terms of for this product, does it have anti-tumor activity? For tumor model, we tend to have two types. One is, we call it ectopic tumor model. That means we take the cancer and plant into the skin, in this case of the nude mice. And here you can see clearly how the tumor, as we increase the dose, the tumor is getting smaller. And if you excise the tumor, you can see how the blood vessels of the control is quite dense, showing that it has full angiogenesis activity. But increasing the dose, you can see the blood vessels getting less and less, suggesting that, hey, the product is working and targeting the endothelial cells. To make it more interesting, we use a orthotopic implantation, i.e. we take the tumor and surgically implant, in this case, the sickle valve for colon cancer model, so that it really represents what tumor environment in the real clinical setting. So here you can see the tumor is shrinking as we increase the dose. To further support this study, because it being a herbal-based extract, you need to, in order to understand what is doing what, we employ array kind of technology or computational modeling, look at the active compounds that has been isolated and do some docking simulation at some of the angiogenesis targets and verify them with a angiogenesis array, protein array platform. And you can see that how the extract can downregulate many of the angiogenesis mediators. So this is already at the pretty much advanced stage. You have from your screening platform, you see that, you know, the study is validating an in vivo environment of a disease model, suggesting that the product may be effective and suggesting that it can be applied in the clinical environment. So again, I would like to emphasize, because you're really using on a safe platform, that means non-cytotoxic, the likelihood of toxicity in the clinical studies will be potentially less. This is a different type of study where we look at wound healing. In this case, using the same platform, instead of anti-angiogenic, we look at pro-angiogenic. Here, we can use the same plant species, but modifying the extraction parameters and plantation condition, we can change the plant from anti-angiogenic to become pro-angiogenic by modifying the chemical constituents. So here we can see that the wound of this particular rat has been excised when applied with the, in this case is the ointment. You can see the wound heal much faster compared to some of standard drugs out there and the control. Hence, this can be applied for diabetic wound perhaps. And we have seen some case studies where this product was applied on diabetic wound. It expedited wound healing. This is another study looking at cervical ovarian cancer. In this case, ectopic. Again, this one was developed based on anti-angiogenic. And here you go, A and B. The treatment, you can see the drug is quite effective. This is another study. We look at glioblastoma. Yeah, the same using the angiogenesis platform. We find that the drug is anti-angiogenic. We implant the tumor into the brain of this rat, and when we excise it, in fact, there's a data for fluorescent molecular tomography showing clearly how the implanted glioblastoma tends to subside after when it was treated with the drug extract. In this one here, we're looking at a very aggressive form of melanoma. So here, the anti-angiogenic herbal cream, which is applied directly on this mouse model, and you can see how effective it was, and applied 3 times a day, and the tumor regressed. In fact, the same product has been applied on certain case studies of cancer patients where the tumor could not be removed surgically. So like around the neck area where they applied the cream formulation, and it showed to be quite effective in controlling the progression of the disease. This is another study looking at lung cancer and same type of platform. And here also we can see that it is quite potent, quite effective, and being anti-angiogenic. So now this kind of study, it is not a miraculous kind of study, but we use angiogenesis as a platform. And we find that this approach has been quite beneficial. That we have 4 products in clinical trial based on this rat erotic ring screening platform, and all of them had good safety profile, 0 dropout in the clinical studies, which is quite important. So we have done studies on hundreds and hundreds of different types of herbs, various solvent extracts. And we find that there are quite a wide variety of plant species out there which you can make them to be anti-angiogenic. And at the same time, you can make them pro-angiogenic, depends on how you process them. So using this platform, you can modify quite easily, and you can get your results within 5 days, and the assay is not very expensive. So these are some of the studies that we have done in animal studies. We look at breast cancer, colon cancer, ovarian cancer, lung cancer, prostate cancer, pancreatic cancer, glioblastoma, melanoma, oral cancer. We also did a diabetic retinopathy, Alzheimer's disease, rheumatoid arthritis, obesity, and wound healing. And all of this was developed based on this angiogenesis screening platform. So these are some of the studies, the clinical studies that we have done. Some of them we have finished phase 2/3 for another one is cancer-related fatigue, and for inflammation related. And we look at COVID-19, and we have done, now we are doing a phase 3 trial for breast and colon cancer based on studies that I presented just now. So lastly, I would like to again emphasize, and I would like to urge my colleagues who are in the natural product development discovery to look into this type of assay for drug development strategy for herbal extracts, i.e. just now I was emphasizing polymolecular, because this kind of assay, they are robust, they are multi-receptor, they can handle multi-compounds. And again, I will say that we have validated this assay in clinical studies, and we believe that using this platform will also benefit other researchers. So I would like to thank you for your kind attention. Thanks.
Thank you, Dr. Amin. All right, so we now will enter the interactive sessions. And participants, you are free to ask questions. And please identify the panelists that you wish to approach. Yeah. So participant, you can unmute yourself. Yeah. All right, perhaps I ask the first question. So I have a question for Prof. Wei Wei and also Dr. Amin. So I think through the presentation just now, I realized that Prof. Wei Wei and also a lot of professors, we are focusing on the identification of new molecular targets and trying to also design new drugs that can, how should I say, target and developing a therapeutic effect, such as anti-cancer activities. This morning, I think Dr. Amin also has highlighted, I think he believed that, you know, we need multiple molecules to counteract multiple molecular targets. So standardized extract with multiple therapeutics appears to be more viable. So wish to seek the comments of Prof. Wei Wei and also Dr. Amin. And perhaps Prof. Wei Wei first. Yeah.
Okay. Yes. Thank you for your good question. As we know, the natural medicines have a good balance with human developing history. Okay, which the good resource of the safety and effective the new drug in clinic. I think it is the main resource of the new drug. However, according to the biological development, the some biological research made the hot point, but the new drug such as the TNF alpha inhibit or the signal transduction inhibitor such as the JAK inhibit can produce the market efficacy, but induce the more adverse drug reaction. At least the reason of this drug due to the excessive inhibition of the immune responses, the cell or molecular the function. So I like to explore the new drug from the natural medicine. Thank you.
Okay, thank you. What about Dr. Amin?
Yeah, this recently we completed a phase 2 clinical studies for diabetic retinopathy. And in that study, based on this herbal drug, which stops angiogenesis, which we saw in animal model, it stops these blood vessels being formed under the retina. And one of the other feature of this herbal drug is it has neuroprotection properties. That means to protect the optic neural nerves. This is an additional benefit of this product. And then that benefits this product is it by itself lowers blood sugar level. So when applied in a diabetic retinopathy environment, it addresses three things like inflammation, anti-angiogenic, neuroprotective, and anti-diabetic. So it kind of like solve the core of the disease problem. Yes, it has other, although in this case, if the patient is diabetic, it may be beneficial. But in combination with modern medicine, say, what about interaction? Are you going to lower the blood sugar of this patient who's normal? So these are the things that we need to address. So a lot of herbal products out there are naturally anti-diabetic, but normal people, if you take them, generally your blood sugar is not going to drop far lower than what it's supposed to be, but it will drop. But these are some of the things that we have to think and address as we learn how to handle polymolecular and in fact, polymolecular, when applied, combined with synthetic medicine in combination, it have a more synergistic role that can have a greater role in terms of the pharmaceutical environment.
Okay, thank you, Dr. Amin. So, what about, okay, Malaysia participants and the China participants? Do you have any further inquiry? All right.
Hello, everyone. I have a question.
Sure.
Do you help me? I have a question. I'm a student from Anhui Medical University, and I have a question for Dr. Chen Haiyong. Because I'm very curious about the concentration of your the intro experiment about the PhD. As you showed in your presentation, like in a vivo experiment, you feed the mouse with the soup using 1 to 2 gram per kilogram, this concentration for your intro experiment. But for the intro experiment, for the stimulating the cells, you didn't show what is the concentration. And I'm very curious. And furthermore, and also because I have never done this similar question before, so I'm wondering in which form you use PhD, like you filter this soup to stimulate the cells, or you use the serum from the patients who took the soup to stimulate the cells. Thank you very much.
Okay, thank you for your questions. So for your questions, I use the granules. This granules is clinically used. We purchased this PhD granules from the pharmaceutical companies, and the dose I think should be 3. We use the 3 doses. One is the 3, 6, and 8 milligram per ml. So we use this granules, clinical granules, because we think this granules is clinically used by the patient. So we did not use some methanol like extractions or water extractions. We just use this clinically used granules. So do I answer your question?
Yes, very clearly. Thank you very much. Thank you.
Okay,
That's
thank you.
all.
Okay, thank you. So any more questions? Participants that is now online, right? I have a short question for Prof. Fotaki, so I hope you are still around. Okay, Prof. Fotaki. So just wondering, because you are actually specializes in this biopharmaceutical modeling, so I wish to ask with respect to nanomedicine's behavior in the blood. Now, it's known that the nanoparticles tends to aggregate. So have you ever developed models with the considerations of nanoparticle aggregations? Yeah. And how does it complicate your modeling? Is Prof. Taki here? or she's offline? All right. So it's okay. What about Mr. Liu? Mr. Liu? Mr. Ken Liu?
Yeah.
Yeah.
Yes. Yeah.
Ah, you are here. That's good. So, Mr. Liu, just wish to know about, I think what you have suggested is rather interesting. And I would like to know, is there any regulatory hurdles if you want to practice it, for example, in the pharmacy setting of a hospital or of the community pharmacy?
Oh, okay. I think it's I mean a two-way in the herbal pharmaceutical extracts in terms of regulatory. We will see that it's when you have extract out the classification. I'm talking about in Malaysia, when you have a herbal extract out, they have a problem that is whether your active ingredients is classified as a herbal supplements or in the using for the we so-called is a under medications, under we so-called poisons. If let's say you have clinical paper to support the medication actually is not using for supplements and only using for therapeutic purposes classified under group poison, the practice have to be like according prescription come up from the medical doctor. But if let's say your herbal extracts, the concentration actually fall in as a supplement or under TCM, the pharmacy actually is safe to be like prescribed or dispense to the patients. But of course that is the mechanism of actions, and also I'm more toward that is the knowledge regarding the herbal medicines application of the treatment for the patients is lesser in the pharmacy practice compared to the modern medicines. I think this is the only like roadblock from the practicing as a pharmacist.
Okay, thank you. So wish to know any more questions from participants who are now online?
Yeah, Professor Wang, I have a question for
sure.
Professor Wei. Okay. Professor Wei, are you there?
Yes.
Professor, yeah, okay. Yeah, I have listened your talk. It's very nice. I noticed that you mentioned the immune software regulation. Maybe it's discovered by yourself. So could you please say more about this theory? And I also want to know, do you find some nature products which is the best to regulate the immune system, to balance them? Is CP25? Thank you.
Okay. Thank you for a good question. As we know, inflammatory immune responses is much important life responses in our body. The normal response protects our body, while the abnormal response is the pathophysiological basis of many diseases, including cancer, serious infection disease, and so on. And now the many drugs, including the play efficacy significantly, but induce the more adverse drug reaction, which is not very good considering balance of the body's inflammation immune response and its physiological functions. So in the new drug research and the clinical rational drug use should be taken seriously, the balance of the efficacy and ADR. not to suppressing excessively cellular or molecular function, but make the pathology of the disease to return to the physiological level. Okay, that is the my academic view of the soft regulation of inflammation and immune responses. As we research the new compounds CP25 to explore the balance, the efficacy, and the adverse drug reaction, that want to obtain the safety and effective treatment for autoimmune disease, such as rheumatoid arthritis and PSS, primary surgery syndrome. Thank you.
Okay, thank you.
Thank you. I also have a short questions to Prof. Rafalski, Prof. Weiwei, and
yes,
also I think Prof. Yi Junju also. Yeah, you know, when I look at the cancer molecular target, so I think nowadays we have omics analysis. We know the molecular target that associated with the cancer of their patients, and hence we prescribe drugs and over specific dose for these particular patients, right? So this is so-called precision medicines or personalized therapies. And with respect to nanomedicines, now nanomedicine is made by encapsulating the drugs using a specific materials, perhaps with a targeting ligand so that they can target the cancer cells. Now, in the human bodies, for example, for cancer patients, so they may express different types of cancer receptor, let's say on the cell surfaces. So assuming if the nanomedicine designer using the wrong targeting ligands, so they may not be able to target the cancer drugs onto the cancer cells effectively or efficiently. And likewise, I think we know that, a lot of us are having some genetic polymorphisms with respects to, let's say, anti-polyethylene glycol immunoglobulin M, right? And a lot of nanomedicine is making use of polyethylene glycol. So they prepare the pegylated nanomedicines so that can reduce the reticuloendothelial clearance of the drugs. So do you think that the personalized therapy, apart from considering molecular target and the drug choice, they should actually consider, for example, the cancer cell surface receptor that have been expressed by the specific patients, the metabolizing enzyme profiles of the patients that may be harmful to the non-drug components of a nanomedicine. Yeah, so this aspect has not been explored or investigated by the scientists. Yeah, I think most of us are looking at omics, molecular target, and on the drugs, but not on the so-called non-drug components of a medicine. So wish to seek your comments. Yeah. Maybe Prof. Rafa.
Okay, yes, excuse me, pardon for my terrible English. So I ask help with translation, my colleague Ksenia. I'm sorry, can you repeat exactly your question? Not comment at all, only a question,
yes,
please.
Yes, yeah. I guess for cancer treatment, so I think nowadays the clinical, they will do the omics analysis, they know the molecular target, and from there they prescribe the right drugs to the patients, the correct drugs. Yeah. I'm just extend my thinking. If I am the one who formulate the drugs into nanomedicine or nanoparticles, so I need to blend the drugs with many different types of materials in order for us to be able to deliver the drugs, to the right place, to the cancer site of the patients. So those are materials that we are using to formulate the drugs. So they may be the wrong materials. For example, if we are using polyethylene glycol, and if the patients, has a high antibody level against the polyethylene glycol, then these materials may be wrongly used to develop nanomedicines for the right drugs. I mean, for the correct drugs. The drug is correct, but the materials they are used to formulate the nanomedicine is wrong, because the patients has a high level of antibody, which will cause the polyethylene glycol clearance. Yeah. So I'm just wondering, let's say from the medical side, have you ever have any concern, about this aspect?
Thank you for your question.
Yes, you are absolutely right.
All right. So,
So
any more questions?
while using our method that we have developed, there is a chance of nanoparticles that we've created while using the method that we've developed. Yes, you're absolutely right.
All right.
Thank you.
Any more questions? Okay, if not, perhaps I will pass the stage to the Master of Ceremony.
All right. Thank you, everyone, for a wonderful and fruitful forum. We would now listen to another closing remark by Professor Dr. Meng Xiaoming, the Dean of School of Pharmacy, Anhui Medical University, China. This speech will be delivered via online. So, Prof, take it away. The floor is yours.
Okay, thank you. Ladies and gentlemen, good times are always very short. Pharmaceutical and nutraceutical innovation is a very interesting and important topic. Many researchers from Malaysia and China work on this area and got very impressive output. This afternoon, we have 7 exciting presentations from our guest speakers. They are all outstanding scientists. They give us very beautiful figures regarding the basic research and clinical translation of drugs from nature products. Again, I'd like to give my sincere thanks to these speakers. In addition, I would like to give my thanks to Professor Kong, Professor Wang, and others, the organizing committee from UITM and AMU for setting this important international forum. It made us come together to share our resources, ideas, and thoughts. To have such a program all in one afternoon is a heavy task, but it really worth the effort. I also wish to express our sincere gratitude to all of you who have so actively participated in this forum to make it such a success. I think everyone must enjoy this afternoon. Thank you. Finally, I have to declare our forum is closed now. We hope the result of this forum will push the innovation research of pharmacy and nutrition to a new stage. We all hope to maintain close contact and cooperation in this research field in the future. Thanks very much.
Thank you, Prof. Dr. Ming. A round of applause. It has
Thank you.
been very insightful indeed, Prof. Ladies and gentlemen, now we would honored to invite Associate Professor Dr. Hasmah Muhyiddin, Assistant Rector, UiTM Samarahan Campus 2, representing Yang Berbahagia, Professor Dr. Jamil Hamali, Rector of UiTM Sarawak, to deliver her speech. Please welcome Professor Hasmah Muhyiddin. A round of applause. The floor is yours, Prof.
Thank you, the MC for today. Bismillahirrahmanirrahim. Professor Dr. Lui Xiong Wen, Vice President, Anhui Medical University, China. Professor Dr. Ming Xiaoming, Deans of School of Pharmacies, Anhui Medical University, China. Professor Dr. Kong Hen Yen, Co-Chair InnoSTRE 2022. Head of divisions, units, head of faculties, all distinguished guests, all forum panelists, virtually and physically, friends from media, distinguished guests, academic, non-academic, and practitioners, ladies and gentlemen, Assalamualaikum, good afternoon, salam Ibu Pertiwiku, and salam keluarga UiTM. Okay. First and foremost, I would like to convey our Yang Berbahagia Rector UiTM Sarawak apologies to all participants as he is unable to be with us physically here today due to his official commitment and duties. Nevertheless, it is indeed an honor for me to be listening and to be with among the accomplished panelists, researchers, and practitioners in their interrelated field and industry. On behalf of UiTM Sarawak, I am delighted to deliver this closing remark on the success of the International Forum on Pharmaceutical and Nutraceutical Innovation in conjunction with the second International Conference on Innovative Sciences and Technologies for Research and Education, InnoSTRE 2020, which is held hybrid. So we are incredibly delighted to co-organize with Anhui Medical University, China, and we look forward to many more fruitful collaborations in the future. This forum has gathered 7 panelists from Anhui Medical University, China, Immanuel Kant Baltic Federal Universities, Russia, University of Bath, United Kingdom, Macau University of Science and Technology, China, University of Hong Kong, Vitais, Sdn Bhd, Malaysia, and Iman Research Ltd, Australia. So the panelists have presented their knowledgeable insight about critical consideration of pharmaceutical and nutraceutical innovations. Once again, on behalf of the committee, we would like to express our heartfelt gratitude to all the panelists and thank you for providing such valuable insights to all of us so that we can deepen our understanding on pharmaceutical innovations. Distinguished guests and participants, drug research has evolved over the years. So apart from the many changes and breakthroughs in the process of drug discovery, emphasis is also now placed on sustainability. We are happy to highlight the most recent innovation in pharmaceutical and nutraceutical areas and identify emerging and future areas of growth and collaboration in this exciting field through the forum interactive discussion. It is such an eye-opener to discover a successful platform in botanical medicine drugs shared by our speakers today. So embedding sustainable practices into pharmaceutical innovation demands innovative thinking with a real sense of urgency. So I believe our forum today has successfully highlighted such urgency that opens the exciting possibilities to engage many countries as crucial players in drug discovery and development. Thank you to our committee members for organizing this international forum and ensuring that it proceeds smoothly. I would also like to apologize any inconveniences that you might have experienced during this forum. So ladies and gentlemen, you have participated actively in this forum, and thank you so much to each one of you for making this international forum a fruitful platform. I hope you have gained beneficial knowledge and prominent insight as take-home messages. Till we meet again, thank you. Terima kasih, Zizi. I hope I said it correctly.
Thank you, Prof, for a insightful speech. But however, Prof, please remain on stage because we are going to invite Professor Kong to join Professor Hasma on stage for Momento presentation. Firstly, we would invite the forum chair, Professor Technologist Wong Tin Hui, to receive his token of appreciation. Secondly, we would invite Dr. Amin Malik Shah Abdul Majid to receive his token of appreciation. All right, thank you everyone. That is the end of our glorious forum. You have been a marvelous audience. Enjoy the rest of the conference. See you again tomorrow. Take care. Bye-bye.
Bye-bye. Thank you.
Thank you. Bye-bye.